thank you so much for the opportunity to speak again. It's been a few years since I've been able to do this in person, and so it's good to see faces and not just a camera in front of me. I actually took this course when I was studying for the board exam. I didn't do it in person, but I did the videos, and I thought they were extremely helpful. So hopefully you'll get a lot out of this. We're going to go through a lot, as evident by the amount of time that you've been given to learn more about infectious disease for your boards. We're going to try to go in some sort of order, but we're realizing that your boards are not going to be in any particular order. So hopefully we'll hit the high parts. So it's a long 4.5, 5 hours. So try to go to your happy place. My happy place is Wrigley Field in Chicago. And so try to think of your happy place, and we'll try to enjoy the next 5 hours together. So the reason I want to start with this is just an overview of antibiotics, in particular beta-lactams. We're not going to go through all the antibiotics that exist. We'll go through different portions of it as we go through each question, because we're going to have about 50-something cases. But I wanted to do beta-lactams just to give a sense of where they sit in the family, how they're related to each other, and what sort of spectrum they cover. So when we talk about beta-lactam, that's a really big family, right? So think about it like the Boudreaux family or the Jones family or something, and then each state has their own family. So right, so beta-lactams have 4 groups, right? Penicillins, cephalosporins, monobactams, and carbapenems. So we're going to start with the OG, right? So penicillin. So when we talk about penicillin, when I talk about here, this is when you actually write the letters P-E-N-I. This is not a form of penicillin. This is actual penicillin. So there's the IV, IM, and PO form, right? As you probably know, IM form is actually on short supply right now. But those 3 forms exist. And what they cover are mainly gram-positives, right? So group A, group B streps, your strep pneumo, Listeria, and actinomyces, which we'll have a case about later. The 1 gram negative they cover is Neisseria meningitidis, and so you can use that to treat meningococcemia. And then the spirochete Treponema pallidum, right, the causative agent of syphilis. So they have pretty good gram-positive coverage, right, but really, really poor gram-negative coverage. And you notice penicillins don't cover staph. I think when they first came out, they did cover some Staph aureus, but not so much anymore. So in addition to the penicillins, we also have the anti-staph penicillins, right? So this is your IV oxacillin, nafcillin, PO dicloxacillin. And their main function is MSSA. MSSA, that's what they're really good for. You don't really use them for anything else. So very, very focused. Our third group is going to be the aminopenicillins. You know them as amoxicillin and ampicillin. So think about these as your gram-positive coverage that penicillin gets. So everything you see on the left side of the screen under gram-positives. It has good enterococcus coverage, right? Obviously, it doesn't have VRE or vanc-resistant enterococcus coverage, but it has really good enterococcus coverage, especially if it's enterococcus faecalis. But the nice thing about the aminopenicillins is that we start adding gram-negative coverage, right? So think about H-flu, MCAT, E. coli, Shigella, Salmonella, and Kingella. And so we think about this is why Amox tends to be, high-dose Amox is the drug of choice for otitis media in kids, right? It covers H-flu for the most part, MCAT for the most part, and strep pneumo, right? So those are the 3 main things you think about when you talk about otitis media. The issue is that these gram-negatives especially have developed resistant mechanisms, right? So you think about your beta-lactamases. So then we had to come up with these drugs called combo penicillins. The IV forms are piperacillin tazobactam and ampicillin sulbactam. The PO form is amoxiclav, right? Amoxicillin clavulanic acid. Think about amsulbactam and amoxiclav as basically the same coverage. If they're doing well on amsulbactam, they're going to do well on amoxiclav. We can't think about that equivocally with piptazo, because piptazo has slightly broader coverage, in particular Pseudomonas coverage and Citrobacter coverage. But these are good for gram-positives, gram-negatives, and anaerobes as well. So these are broad-spectrum therapies. And when you're thinking about treating kids, it's okay to start broad-spectrum therapies, but the idea is that you want to de-escalate over time to something closer to the left side of your screen on a penicillin basis. So very broad to very narrow. And those are your penicillins. So when we talk about different penicillins later on in the talk, we'll try to note the difference. Then we go to cephalosporins, right? So these are based off of generations, right? First generation tends to have more gram-positive, less gram-negative. And as we go up the generations, we have more gram-negative coverage. So your first generation IV cefazolin and PO cephalexin, very similar to the penicillin group, right? But you add MSSA to this. And that's an important piece because for the most part, we tend to use first generation cephalosporins more often for MSSA infections, mainly because you can give the IV forms less often than your anti-staph penicillins, the nafcillin, oxacillin. And when you do PO, the cephalexin is much tastier than dicloxacillin. And so for the most part, for MSSA infections, we tend to use first generation cephalosporins. And they get a little bit of gram-negative coverage, in particular E. coli and Kingella. So we now have second generation, cefotetan and cefoxitin IV, and then PO cefuroxime. The key here is that the IV forms will get gonorrhea, but they also get anaerobic coverage. And so we think about that in terms of kids who might have appendicitis or ruptured appendicitis. It has good gram-negative coverage for your enteric gram-negatives, but also has anaerobic coverage. And so sometimes you'll see our surgeons put these kids on second generation cephalosporin. Third generation, right, we're all very familiar with this, right? So especially vitamin C, right, ceftriaxone, where kids get a lot of that. And we use it a lot because it has really good gram-positive coverage, but also really good gram-negative coverage. When we think about the things that, especially ambulatory pediatrics, the things that you worry about in ambulatory pediatrics, third generation cephalosporins cover pretty much anything you're worried about, for the most part, right? There are also nuances, immunocompromised kids, et cetera, but for the most part, this class of drugs will cover all the things you worry about in ambulatory pediatrics. The one note is that ceftazidime, a third generation cephalosporin, does have Pseudomonas coverage as opposed to the other IV options, ceftriaxone and cefotaxime. The orals do not have Pseudomonas coverage either. And then we get fourth generation, right? So very broad, right? Similar to what we did with the penicillins, we went from fairly narrow to more broad coverage. We're doing the same thing with cephalosporins, in particular with gram-negative coverage. And so cefepime covers lots of gram-negatives, including Pseudomonas. It tends to be somewhat stable against ESBLs or extended spectrum beta-lactamases, but also has decent gram-positive coverage as well. And then we have the unique thing about fifth generation. So this is ceftaroline. We think about that basically like a third generation cephalosporin like ceftriaxone or cefotaxime, but it adds MRSA coverage. We lose Pseudomonas coverage, but we do gain MRSA coverage, and this is the only cephalosporin that has MRSA coverage. So those are your cephalosporins, right? So we've covered a lot in a very short amount of time about these antibiotics. And again, we're going to talk about cases where we use some of these drugs. The two last groups I want to mention about beta-lactams are the monobactams, right? This really aztreonam, which has really good gram-negative coverage. And you can usually dose it once a day. And so it's very nice when you especially thinking about outpatient parenteral antibiotic therapy. Sometimes we'll use aztreonam. And then we use carbapenems. These are the broadest, really, of drugs. So we think about, big gun antibiotics. In my mind, big gun means how broad is the spectrum of coverage. And the carbapenems are really the biggest. And that's meropenem, imipenem, and doripenem. We typically use meropenem most often in pediatrics. Imipenem is typically married to a beta-lactamase inhibitor, and that group tends to actually lower seizure threshold in kids, and lots of kids have seizures, so we try not to lower that threshold. And so we typically use meropenem, and it's very broad. The only thing it doesn't cover is Enterococcus and MRSA. Otherwise, it covers everything else. So all gram-negatives, all anaerobes. You typically don't need meropenem and anaerobic coverage with something like metronidazole because it's duplicative coverage. And so meropenem, imipenem, and doripenem are very, very broad. So again, okay to start those empirically in kids in the hospital, but you always want to de-escalate to something else. Okay, so we're done talking about this particular group, right? So beta-lactams. So we'll start going into our cases. So we have a 14-year-old female who presents with fever, chills, and a history of flu 1 week ago. She now has a cough and left-sided pleuritic chest pain, and X-ray shows left lower lobe pneumonia with effusion. The gram stain from a positive blood culture reveals gram-positive cocci in clusters such as that seen here. Which is the appropriate antibiotic to begin for this patient? Is it A, oral amoxiclav, B, IV Vinc, C, IV ceftriaxone, D, IV ampicillin, or E, IV vancomycin and piperacillin tazobactam? All right, so answer is IV vancomycin. The majority of y'all got this correct. So when we think about this, let's go. So about a little over a decade ago, there was a report from the MMWR that talked about the amount of staph pneumonia that occurred after people had influenza, and these were otherwise healthy folks. This happened in Georgia and my home state of Louisiana. And since then, we've had a keener eye on post-influenza staph pneumonias and the severity of those. And so when we look at this particular case, we have a history of flu 1 week ago, and staph is usually seen after influenza. Although now we've noticed that there can still be bacterial pneumonias that aren't Staph aureus after respiratory virus. The chest X-ray shows left lower lobe pneumonia with effusion, which is pretty classic for bacterial pneumonia, sometimes with staph. But staph, you'll also see abscess and hematocele. You can even see that into a few days of therapy. And then the gram stain shows gram-positive cocci in clusters, such as that seen here. So that would suggest that it's a Staph aureus infection, and empirically we want to start those kids on Vanc. We don't use Vanc and Pip/Tazo usually because there's an increased risk of acute kidney injury in those kids, and the boards want you to be as specific as possible when it comes to antibiotic selection. And so when they give you a blood culture that's suggestive of Staph aureus, you don't need to put them on Vanc and Pip/Tazo. You put them on just straight vancomycin. We don't use oral amoxiclav because amoxiclav is not going to have MRSA coverage. For kids who are admitted to the hospital, we typically get a blood culture and a CRP. If you're going to treat these kids who aren't quite as sick in outpatient therapy, we typically don't need to get a blood culture and a CRP. Okay. So when we talk about MRSA treatment, we have a number of options. So one is clindamycin. So if clindamycin was a choice for this particular kid, if they didn't have bacteremia, you could choose clindamycin because it does have really good lung penetration, but you don't want to use it for bacteremia, at least empirically. You always want to start with vancomycin and then de-escalate to clindamycin if you can. But clindamycin is really good. It has good bioavailability, but it's not perfect. So IV is not the same as PO. Clinda is much tastier now than it used to be in terms of oral therapy. TMP, and it also depends on your location. So some places have a good amount of Clinda resistance when it comes to Staph aureus. Some do not have much resistance, and so it depends on your location whether or not you can use Clinda empirically. TMP SMX is really good for MRSA. IV and PO are basically the same, so you don't need to give IV TMP SMX very often unless there's this reason that the patient can't take enteral TMP SMX. And it's good for staph, but it does not have group A strep coverage. So if you're worried about group A strep causing your infection, you would not choose TMP SMX. Vancomycin we talked about, again, it has to be IV. PO vancomycin does not have systemic absorption, so you don't want to give PO vanco for a kid with a staph infection. Linezolid is really good. It gets really good into the lungs. And it also, similar to TMP SMX, has really good bioavailability. So giving it PO is basically the same as giving it IV. Daptomycin is good unless you have a lower respiratory tract infection, in which case it's inhibited. And so you don't want to use it for kids with pneumonia, but we do use it at times when we have persistent bacteremia due to an osteo or something like that. Doxy is really good for staph, similar to TMP SMX, does not have group-based strep coverage. And we typically use Doxy in kids 8 and older because of the concern for teeth staining. Ceftaroline, we mentioned, 5th generation cephalosporin that has MRSA coverage. And then rifampin. We typically don't use rifampin by itself. We usually use it in combination with some other anti-staph drug because the ability for the staph to become resistant pretty quickly as with monotherapy is high. We use rifampin when it comes to hardware or foreign material that's infected because it penetrates biofilms really, really well. And so oftentimes we'll use rifampin with that. Rifampin, similar to TMP-SMX, linezolid, and doxy, has really good bioavailability. So those four you can give enterally and have the same effect as given it IV. As you probably know, in pediatrics, most lower respiratory tract infections are caused by viruses, more so than bacteria, so always think of that first. We talk about community-acquired bacterial. We talk about some of these later on in some of our slides, but in terms of what we treat them with, so strep pneumo, also known as pneumococcal infection, in group A strep, we typically use penicillin, as we referenced in that first table when we looked at beta-lactams. H-flu and MCAT, if they're beta-lactamase negative, we could typically use amoxicillin. If they're beta-lactamase positive, we use amoxiclav, right? The clav is a beta-lactamase inhibitor, so it inhibits the beta-lactamase being produced by the gram-negative, or we can use second or third generation cephalosporin. The atypical is Mycoplasma and Chlamydia pneumoniae. We will use azithro or doxy. And then Staph aureus, we'll use Vanc or Clenda or linezolid, depending on the clinical situation. I have here not MSSA, right? Because remember, Vanc will treat MSSA, but it's inferior to your anti-staph penicillins or your first-generation cephalosporins. So if you have MSSA, you should not be on Vanc, you should not be on Clenda. You have better therapies for MSSA. All right, case 2. We're just flying by these cases, I tell you. All right, case 2. 4-year-old male was diagnosed 1 week ago with chickenpox. 1 day ago, he developed fever and chills. He presents to the emergency department with the following on exam: blood pressure 40 over palp, respiratory distress, conjunctivitis, and a desquamating red macular rash. His labs reveal an ALT of 331, a creatinine of 3, and a platelet count of 20,000. Blood culture is positive after 8 hours. Which of the following is the most likely diagnosis? Severe varicella sepsis, EBV, toxic shock due to E. coli, toxic shock due to strep pyogenes, or toxic shock due to Staph aureus. All right, toxic shock due to strep pyogenes, also known as group A strep. So most put Staph aureus. Okay, this is why we put this case in here. This is not severe varicella sepsis because usually those kids are going to be immunocompromised. You typically don't have a desquamating rash or conjunctivitis. EBV doesn't usually cause this severe of disease unless you're immunocompromised and have something like post-transplant lymphoproliferative disease. E. coli doesn't really have a toxic shock syndrome associated with it. You can get, obviously, sepsis with E. coli, but it doesn't usually cause the conjunctivitis or desquamating rash. So then you're right, you're between the two you mostly picked, right? Strep pyogenes or Staph aureus. So in this case, it was group A strep. We're going to talk about why in just 1 second. But first, I'd like to know what you want to do for this kid. In addition to fluid resuscitation, the most appropriate therapy for this patient, now that you know the diagnosis, is what? IV Vanc and IV Pip/Tazo, IV ceftriaxone, IV penicillin and IVIG, IV penicillin and IV clindamycin, or IV Vanc and PO linezolid. All right, so answer choice D, IV penicillin and IV clindamycin. Okay, and then the second most common answer was B, IV ceftriaxone. Okay, so let's think about this case, right? So for if we know this is group A strep, we don't need Vanc and Pip/Tazo, right? That's certainly overkill and the risk for acute kidney injury. You don't need both of those. IV ceftriaxone, so IV ceftriaxone, you're right, will cover group A strep, not a problem, right? Meropenem will also cover group A strep, right? But it's a really big drug for a really, I don't want to say a small bug, but a bug that can be killed by penicillin. The other thing is ceftriaxone isn't ideal for toxic shock syndrome because in this answer choice, you're not given clindamycin. And clindamycin is good because it has a toxin-mediated effect against toxic shock syndrome. So you always want to give clindamycin when you have toxic shock syndrome, whether it's due to group A strep or Staph aureus. For C, every now and then we'll use IVIG clinically, but there's little to no evidence that says that it's very helpful. Usually it's when kids are super sick and we're just sort of doing what we can. But there's no evidence that say that it's very effective. And then for E, IV vanc, obviously we don't need vanc for group A strep, and there's no role in peel and linezolid for this particular situation. So for this kid, right, so chickenpox, right, so we don't see it very often anymore, but one of the things that we did see quite a bit was a secondary bacterial infection after varicella due to group A strep. So that's just a historical association you need to know with varicella and group A strep. And then as you all could tell, this kid was in shock, right, so hypotensive. The key pieces here are respiratory distress and culture is positive. Right, those are the two clues that it's group A strep versus Staph aureus. When you have toxic shock syndrome, whether due to Staph aureus or group A strep, a positive blood culture is more likely with group A strep than for Staph aureus. You also get more respiratory distress and compromise for group A strep than for Staph aureus. I'm not saying it can't happen, but for your boards and from a more often, it's going to be group A strep doing this, right? And the desquamating red macular rash, right? Think about a sunburn kid who comes in with hypotension. You're concerned about toxic shock syndrome, and then sort of a table that sort of differentiates the two. And it's sort of a spectrum of disease. And when you look at the Red Book, it talks about the criteria of definite versus probable or possible. And sometimes because of the severity of illness of kids, clinically, we'll start therapy and sort of call it one of these, but think about trying to differentiate the two. Group A strep is going to have a positive blood culture and respiratory symptoms. Okay. Case 3. A 12-year-old male presents to the ER with fever, decreased appetite, and pain in the right lower extremity that has progressed over the last 2 days. He played in a football game a week ago and was fine. The exam reveals a temperature of 103, heart rate of 110, respiration 16, a blood pressure 100/60. His right distal thigh has swelling and mild overlying erythema and is tender to palpation. He has a CRP of 245 milligrams per liter and a white count of 17,000. The plain film is negative for a fracture, and an MRI reveals the distal femur osteomyelitis complicated by subperiosteal abscess and localized myositis. In addition to consulting an orthopedist, which antibiotic regimen would you initiate? IV cefazolin and IV vanc, IV cefazolin, IV vanc, IV cefepime, or IV doxycycline? Okay, so IV vancomycin. So most people picked IV cefazolin and IV vancomycin. So we'll get to that in just a second. But the reason that's not correct is because you don't need it for this particular case. We don't need IV cefazolin by itself because we worried about MRSA infections in bone infections, right? So we think about bone and joint infections, we think about skin and soft tissue infections. The two things we think about are Staph aureus, group A strep. Staph aureus, group A strep. Staph aureus, group A strep. Right, so you're good to think about Staph aureus and group A strep being a causative agent for this. The reason this is vancomycin is because you're worried about staph, and this kid, while sick, he's going to be in the hospital, isn't septic, isn't in shock, and so you try to use monotherapy when you can. We don't use IV cefepime because it's not necessary in this point. We're not really worried about Pseudomonas in this particular case. IV doxy, doxy might be a fine choice. But we don't need it IV. Remember, its bioavailability is almost 100%, so you typically give doxycycline intraorally. Okay, so let's think about this, right? So we talked about osteo, trauma. So again, most osteo and septic arthritis in kids is hematogenious spread, which is why it's good to get a blood culture in these kids because you might be able to identify the pathogen. But sometimes in kids, it's going to be very minor trauma, right? So they ran into the coffee table, but they kept running. And so it's very minor trauma in pediatrics. And then The plain film is not going to show osteo for about 2 weeks. And so don't get fooled if they say the kid's been symptomatic for 4 days and you get a plain film that's negative for osteo. It doesn't mean it's not osteo, it just hasn't shown up yet. And the MRI typically is the drug of choice for this. The one thing I'll say about the labs, the CRP of 245 milligrams per liter, my hospital uses this value. Some places use milligrams per deciliter. So just be aware of that, because in this case, if you were to use milligrams per deciliter, it would be 24.5, which to me is not very exciting. But just be aware of what the labs show. Okay, so think about that case and think about this case. They're similar. So a 2-year-old male who attends daycare presents to the emergency department with fever, decreased appetite, and refusal to walk that has progressed over the last 12 days. He played outside with some older cousins last week, but was not as rambunctious as usual. Exam has a temperature of 100, heart rate 110, respirations 20, blood pressure 90/60. He is rather playful. His right distal thigh has swelling and mild overlying erythema, along with right knee swelling. The whole area is tender to palpation. Labs have a CRP of 45, a white count of 17,000. Plain films are clear for fracture. MRI shows a distal femur osteo and a right knee effusion. A joint effusion aspirate reveals a white count of 30,000 and a negative gram stain. In addition to consulting an orthopedist, which antibiotic regimen would you initiate? A, IV cefazolin and IV Venco. B, IV cefazolin. C, IV Venc. D, IV cefepime. And E, IV doxycycline. Okay, B, IV cefazolin. Anybody want to know why IV cefazolin? Anybody know what bug this is? All right, Kingella. I heard somebody say Kingella. Right, so this is Kingella, right? So this is a slightly different kid than the kid we just talked about, right? And this is what the boards do. They give you little nuances, and this is why I do these cases, to be able to distinguish why one answer is the correct answer for one case, and a very similar case has a different answer. So let's see, so this is a 2-year-old male. So you think about this age group, you think about staph, you think about group A strep, absolutely, but then you add Kingella, right? So we'll talk about Kingella in just 1 second. It's a gram-negative that we see in kids less than 5. They typically attend daycare, which this kid does. And the key here is that this kid doesn't seem nearly as sick as the prior kid, right? He's been hanging out for about 2 weeks, still playing, not really febrile. His CRP is not quite as high as the last kid. Joint effusion only has 30,000 whites, negative gram stain. You're typically not going to see gram negatives on a gram stain for Kingella. Now, the other thing about this kid is 2 years old, if they have septic arthritis because of the way their blood vessels go to the bone, to the joint, if they have a septic arthritis, chances are they have an osteo. If they have an osteo, chances are they're going to have a septic arthritis, usually in kids who are up to 2, 3, 4 years old. So if you have a septic arthritis, you still need to do an MRI to look for adjacent osteomyelitis. And so for this kid has Kingella, and the drug of choice is a first, second, or third generation cephalosporin. Now, clinically, would I add staph coverage? Probably, but the boards want you to know exactly what the bug is and what specifically you would treat it with. All right, so in this line of questioning, this is the last one regarding this. So a 12-year-old male comes to the ER with fever, decreased appetite, and pain in the right lower extremity that has progressed over the last 2 days. He played in a football game a week ago and was fine. Exam has a temperature of 103, heart rate 130, respirations 40, and blood pressure 65/35. He has his right distal thigh swelling and overlying erythema, and the area is tender to palpation. He has a CRP of 245 and a white count of 17,000. Plain film is negative for fracture. His MRI shows a distal femur osteo complicated by a subperiosteal abscess and localized myositis. He gets 3 IV fluid boluses, and after that, he has a blood pressure of 70/30, heart rate of 125, and SpO2 of 75%. In addition to consulting an orthopedist, which antibiotic regimen would you initiate? IV cefazolin and IV Venc, or B, IV cefazolin by itself, C, IV Venc by itself, D, IV cefepime, or E, IV doxycycline? All right. So IV cefazolin and IV vancomycin. Yes, everybody got this. Fantastic. Well, most people got this, right? So what's the difference with this kid? He's really sick, right? Right. He's really sick. So in this case, are you worried about Kingella in this kid? Right. He's an older kid. Don't worry about Kingella. So we're worried about what? Staph aureus, group A strep. Right. So for this kid, we're worried about MRSA, MSSA, and group A strep. Right. And what we said earlier is that vanc is fine for MRSA, not as good for MSSA, and not that great for group A strep. So this is when you add double coverage for this kid who is sick, super sick. Right, so you're going to add MSSA group A strep coverage specifically with IV cefazolin, and you're going to do IV vanc for MRSA coverage. Now, once you get your cultures back and whatnot, you can always de-escalate to what you need it to be. But for this kid, you want both MSSA-directed therapy and MRSA-directed therapy. So again, the clue that this kid was septic, and you do double coverage for this. And so we talk about Kingella, right? So this is common in the throats of toddlers, especially in daycare. It is difficult to grow in culture. I think I've seen one case when we had a positive Kingella grow from a culture. We typically see, we diagnose it with a PCR, usually from the sample taken from the osteoarticular infection. Again, compared to Staph aureus, it doesn't have the robust inflammatory response, and so you're not going to see a CRP of 245. And again, it's a broad treatment regimen, so you can use a first generation, second generation, third generation cephalosporin. It doesn't matter. Again, try to use as narrow as possible. It's resistant to vancomycin, right? Because vancomycin we'll sometimes use empirically for bone and joint infections, right? Because it has Staph aureus coverage and group A strep coverage. They have no gram-negative coverage, right? And Kingella is gram-negative, so you need to add some sort of gram-negative coverage. So bone and joint infections we already mentioned, right? Group A strep, Staph aureus. Sickle cell disease is Salmonella. It is more common than Staph aureus. We diagnose joint infections usually with ultrasound, bone infections with MRI. Treatment, depending on your location, sometimes we can use Clunda if they're not that sick and you know your local antibiogram, or we use vancomycin, especially if we know they're bacteremic, we use vancomycin empirically. When we talk about IV to PO transition, so it used to be we treated all kids with IV antibiotics for bone and joint infections. We don't do that anymore, typically, mainly because the benefits do not outweigh the risks. So what we typically do is at least 72 hours of IV therapy, and then they have to be afebrile for 24 hours, have sterile blood, and their CRP down by at least 20%, right? CRP is not going to be normal, but at least down by 20%. Usually at that point, we feel comfortable going from IV to PO therapy. And we typically treat these types of infections, joint infections, anywhere between 2 to 4 weeks, depending on which joint, with the hip being one closer to 4 weeks. And then bone infections, we typically do about 4-ish weeks, knowing that less than 3 weeks is people are going to fail at less than 3 weeks, but we do typically about 4 weeks, 4 to 6 weeks. So just to transition now a little bit to gram-positive bugs. We already talked about Staph aureus, coag-negative staph is oftentimes a contaminant unless the sample is taken from hardware. And that includes central lines, that includes VP shunts. Hardware is what coag-negative staph really likes. And so think about that in the setting of organisms when kids have hardware. Strep pneumo we'll talk about, group A strep we'll talk about a little bit more, group B strep, and that penicillin is the drug of choice. So you notice, again, penicillin is the drug of choice for a lot of these gram-positive organisms. So you don't have to do high-dose amoxiclav for group A strep, group B strep, strep pneumo for the most part. And then we'll talk about group C and G later that can cause osteoarticular infections and bacteremia, but more commonly, it's going to cause pharyngitis in adolescents, but the treatment is penicillin. So group A strep, right, we think about it with scarlet fever. We think about the picture in the middle are the pastilla lines that you can see here that are pretty classic for group A strep, and then the strawberry tongue. Again, strawberry tongue is not specific to group A strep, and we'll talk about some other manifestations or other systems, other illnesses that you can see a strawberry tongue with. Group B strep, right? So there's two things we really about with group B strep, right? There's early onset sepsis and late onset sepsis in newborns. The early onset being up through 6 days of age. Usually it's going to be within their first few hours. Oftentimes the most common presentation is sepsis and then pneumonia. And and the case fatality rate is 5 to 15%, although intrapartum antibiotic prophylaxis has dramatically decreased the morbidity and mortality of these kids. And so screening moms for group B strep and then treating them appropriately with IAP has been shown to be very beneficial. Less so with group B strep late onset disease. It doesn't appear that IAP, for whatever reason, doesn't have a dramatic effect on the incidence of this. Most of the time, it's going to be bacteremia without a focus, and then followed by meningitis, and then bone and joint infections, or cellulitis and adenitis. We culture group B strep. That's the diagnosis. That's the gold standard. The treatment is usually either penicillin or ampicillin with GENT initially. Then we kind of peel the GENT off once we sterilize things. The duration sort of depends on the clinical manifestation, right? So pneumonia and sepsis we do 10 days. CNS disease is at least 14. Bone and joint, again, similar to bone and joint, we do other things about 3 to 4 weeks. All right, we'll go to case 6. A 16-day-old female presents to the pediatrician's office with the rash. She was born term via vaginal delivery to a mom with an uneventful pregnancy, other than antibiotics for asymptomatic bacteria around 28 weeks of gestation. Mom has no history of cold sores or genital lesions. Baby has a temperature of 99.9, a heart rate of 120, respiration's 20, blood pressure 87/55, and she has a rash that looks like this. Okay. What diagnostic test or tests would you like to do next? A blood culture and chest x-ray, an HSV PCR from the rash, the lumbar puncture, HSV PCR from the rash and an MRI of the brain, D, a viral culture from the rash and an EEG, or E, a nasal swab for viral culture and a right upper quadrant ultrasound. All right, so it'd be an HSV PCR from the rash, the lumbar puncture. Oh yeah, all right, most of y'all got this, right? So blood culture and chest x-ray, that's when you're concerned about community-acquired bacterial pneumonia, which this kid doesn't seem to have. MRI of the brain, you wouldn't do that immediately. You probably do it at some point, but not immediately. A viral culture has decreased sensitivity compared to a PCR, so we tend not to do viral cultures very much at all. An EEG maybe down the road if you need to. And then a right upper quadrant ultrasound isn't indicated in this particular case, nor is a nasal swab for viral culture. Again, we prefer to do PCRs for HSV now due to increased sensitivity, right? So the clues here are 16-day-old. So we think about what happens around 2 to 3 weeks of life, and HSV is a very common thing. Oftentimes, it's going to be mom has no history of HSV, right? And the reason the reason I worry more about when I get called about moms with no history of HSV versus mom who has a history of it, right? So mom, when they have an infection due to HSV, they're going to have IgG. They're going to make IgG, and that's what goes across the placenta, so it protects baby. And so, a primary infection is more severe than a secondary infection for the most part. And so, typically, moms are not going to have a history of HSV, and therefore, baby's not going to be protected with IgG. So oftentimes you'll see moms don't have a history of HSV infection. And in the rash itself, so usually going to be an erythematous base, these vesicles, and oftentimes they sort of coalesce like a few of these do. And that's concerning for HSV in this case. And so we talk about HSV and then neonate. So neonatal HSV sort of presents itself in 3 flavors, right? So there's one skin, eye, mouth, or SEM disease that usually occurs in the first 2 weeks of life. If you had to have one, that's the one to have. The morbidity and mortality is almost non-existent. The key, though, is you always have to check an LP in kids who have SEM disease. Anywhere between 60 to 80% of kids, 2/3 of kids with SEM disease is also going to have CNS disease, but they might not manifest it initially. It might be skin, eye, mouth initially. So any kid you have suspicion of SEM, you need to do an LP. Disseminated disease, again, occurs within the first 2 weeks of life. These kids are super sick. These are the ones who typically go to the PICU really quickly. Oftentimes they're on ECMO, and they are severely ill. And then CNS disease is a little bit later, usually second or third week of life. This is why you do an LP and can have skin lesions. Treatment for neonatal HSV is IV acyclovir, 2 weeks if it's SEM disease, and then 3 weeks for disseminated and CNS disease. When you have CNS disease, you always want to repeat an LP around day 18 to 19 of therapy to ensure that you're PCR negative after that. And then regardless of which flavor you have, these neonates need to be on suppressive therapy with oral acyclovir for about 6 months. So PO acyclovir for 6 months, regardless of which flavor they have of neonatal HSV. Other ways HSV presents itself outside of the neonatal period, we think about oropharyngeal, right, gingival stomatitis. So sometimes it can be bad enough to where they have dehydration and need to be admitted to the hospital, and this is where oral therapy can actually decrease signs and symptoms and decrease transmission. You can have genital HSV, and don't forget, in kids especially, you can have self-inoculation of HSV. So while you certainly think about child abuse and neglect, also think about self-inoculation. Encephalitis can happen in older kids. It can be pretty devastating. One key term to think about on your board exam from an EEG standpoint is PLEDs, or periodic lateralizing epileptiform discharges. You'll often see that when you have kids who have HSV encephalitis. It's not pathognomonic for HSV. You can also see it in things like strokes, brain tumors, or multiple sclerosis. But in the right vignette setting, think about HSV in that particular situation. Keratitis, you always want to call opto and get their evaluation as well for HSV. All right, we'll go to case 7. A 6-year-old male presents with left arm redness and swelling for a few days, slight decreased appetite, but is drinking normal. Parents do not have a thermometer at home, but they do report he is warm to the red area on the arm. It has not come to a head per parent. There are no sick contacts, no recent antibiotics. Temperature 98.3, heart rate of 90, blood pressure 100/57. The exam reveals a cooperative child with firm erythema measuring 3 by 5 centimeters with a well-demarcated border. It is rather tender, but no fluctuance or drainage is noted. The best therapy for this patient is A, doxy, B, ceftonir, C, amoxiclav, D, Piovanco, or E, penicillin. All right, E, penicillin. Okay, so there's a tie between penicillin and amoxiclav. So let's think about this for a second, right? So no recent antibiotics, so we're not worried about a drug-resistant bug of any sort. When the boards give you a clue like that, you don't need to think about a multi-drug resistant organism. The patient is afebrile, so it's not a terribly aggressive pathogen, whatever it is. And the key here is that there's no fluctuance or drainage, and well-demarcated borders, and it's very tender, right? So this is erysipelas, right? And erysipelas is due to group A strep, right? So we talk about what group A strep is covered by. The narrowest we can get on that list of choices was penicillin, right? Would amoxiclav cover it? Yes, amoxiclav is not a wrong answer clinically, but you're covering a wide range of bugs when you don't need it. You only need to cover for group A strep. When you think about the answer choices, doxy, right? If this is group A strep, doxy is not going to cover this. Also, it's a 6-year-old. You try not to give a 6-year-old doxy, except for a few circumstances we'll talk about later. Ceftonir would be fine. It would cover group A strep, but you don't need that broad of coverage for group A strep. Amoxiclav, same thing. Piovanco, like we talked about earlier, has no systemic absorption and isn't the drug of choice for group A strep. Again, if this were purulence, if this were a true abscess, then you think more about Staph aureus causing that than group A strep. So skin soft tissue, right? So Staph aureus and group A strep, right? Sounds similar to bone and joint, right? Staph, group A strep. Cellulitis, if it's purulent or an abscess, it's more likely to be MRSA than MSSA, and more likely for both of those to be than group A strep. Treatment is usually Clenda, TMP-SMX, or doxy. Non-purulent, think more group A strep. Sometimes MSSA can do it as well. Fortunately, you can use a first-generation cephalosporin to cover both of those. And then erysipelas, which this case is group A strep, in which case you can use penicillin. All right, so we'll get off skin, soft tissue for the moment. Case 8, a 7-year-old female born at 38 weeks gestation via normal spontaneous vaginal delivery was discharged home 2 days after birth. Chotability was 8.2 prior to discharge, but since she has been home, parents feel her jaundice is worse, and they have noticed a few spots on her belly. Her vitals are stable, and she is afebrile. She is jaundiced, and you note pinpoint red spots on her face, chest, abdomen that are consistent with petechiae. Her exam is otherwise unremarkable, other than microcephaly. She has a platelet count of 62,000, a bilirubin of 10 with a direct bili of 5, an ALT of 151. And her cranial ultrasound shows calcifications. The next best step in management is A, a serum cytomegalovirus PCR, B, an HIV antigen antibody test, C, an RPR, D, CSF HSV PCR, or E, a blood culture. All right, so the answer is A, serum cytomegalovirus PCR, which most of y'all got, which is great. Right, so this is congenital CMV. It could be HIV, but probably not. But even if it were, you wanted a test for HIV, you do not do an HIV antigen antibody test in a neonate. Why? Right, moms, right? You're going to have mom's IgG that's going to be positive, and so you can't. So for HIV, we do PCRs in babies. This doesn't seem like RPR. Certainly, babies can present with jaundice, occasionally petechiae, but the cranial ultrasound showing calcifications sort of rules it out. HSV PCR, a kid, you don't need calcifications with that. In a blood culture, right, there's no fever in this kid, so no real indication to worry about neonatal sepsis at this point. So, right, so a serum CMV PCR. The other consideration in this case would be toxoplasmosis, right? That also causes that also causes calcifications. And we'll talk about the differences, but CMV is more common. So if you have a question between the two and the vignette doesn't give you a clue, one versus the other, and I'll tell you why. Another reason this isn't toxo is typically going to have hydrocephalus. So you get microcephaly, but you also have hydrocephalus. And they'll usually give you that as a distinction between CMV and toxo, and then where the calcifications are. So we've talked about this, right? Thrombocytopenia, hyperbilirubinemia, especially an elevated direct, is going to be indicative of a CMV infection. So thinking about torch infections. So we'll get back to CMV and toxo in just a second, but we'll go through some of the torch infections. So perinatal history for HIV, when mom is not on therapy, there's a really decent chance of mother-to-child transmission. When you put a mom on zidovudine alone, there's a great diminishing transfer. And then if mom is on highly active antiretroviral therapy, there's a really, really low percent of kids who get infected. And we now have a risk category based off of new guidelines of whether or not you're low risk or high risk based off of mom's viral load. Basically, if mom is undetectable, that's low risk. If mom is detectable from a viral load standpoint, that puts them at high risk. And the reason that matters is what we're going to use for preventative therapy on baby. If baby's low risk, we're going to use monotherapy with zidovudine, usually for 4 weeks. And if baby's high risk because of mom's viral load, we typically do 2 to 3 drug therapy, more commonly 3 drug therapy. Oftentimes we'll do that for about 6 weeks total. Usually with zidovudine, lamivudine, and nevirapine. HIV-exposed babies do not get pneumocystis prophylaxis, so you don't need to start them on TMP SMX. We typically test, again, PCR. We don't do antigen antibody. We do that for older kids and adults. We do PCR at usually 2 weeks, 4 weeks, and 4 months. If any of those are positive, we repeat immediately for confirmation. But a negative PCR test at least 1 month of age and at least 4 months of age essentially rules out HIV. HIV is certainly much more common. HIV-1 is more common than HIV-2. One thing that shows up on the boards quite a bit are needle sticks. I'm doing MOCA right now and it's still showing up. And the key is to wash the wound really well, get baseline serologies, but you do not give antiretroviral therapy. It's not indicated. And it's funny how they come up with lots of different scenarios for needle sticks, but the answer is always the same. So when we talk about acute HIV infection, it's the earliest portion of that. You usually don't have antibodies yet. The symptoms of acute HIV in adolescents is going to look like a really decent flu or maybe like mono. The key component of trying to isolate or identify individuals with acute HIV is because while they constitute a very small portion of folks who have HIV, they account for over half of the transmission, right? Because you have a high viral load, you don't have any antibodies yet, and you're not on therapy, and so the risk of transmission is much, much higher, which is why there's a push to screen folks in urgent cares, in the ER for HIV. Again, older kids, we don't do PCR as a screening test. We do the antigen antibody test, like the 4th generation testing we'll talk about in just one second. If any of those are positive, we get a CD4 count. We do a viral load, and then we do a genotype, which gives us a resistance profile, and we start therapy when results are known. When I was training, there was a question of which kids to start therapy on, kind of based off their labs and age and signs and symptoms. Now, all kids get started on therapy when they're diagnosed. So this is just a graph of what we look at in terms of testing, right? So if we look at this is sort of days from infection. And so we typically think of retroviral symptoms starting here. Again, that's what's going to look like a EBV infection or a decent flu. The 4th generation testing, the dark green bar is gonna show up after about 10 to 14 days of infection, which is slightly later than when RNA testing is going to show up. So your PCR is going to be positive first because you're looking for genetic material, and then the antigen antibody test reveals your response, your immune response to the infection, which might take a little longer to show up. So for neonates, we do PCR because mom transmits IgG to baby, which is protective. But for kids, usually 2 years and up, we will do antigen antibody testing. Antigen looks for the virus itself, and antibody looks for the immune response to it. The combination of nucleoside and nucleotide reverse transcriptase inhibitors with either a protease inhibitor, an integrase strand transferase inhibitor, or a non-nucleoside reverse transcriptase inhibitor are what we use. We always get a resistance profile before we start therapy to know what we're looking at. And we do labs every 3 months. It's okay to vaccinate these kids if they have a good CD4%. In kids, we typically use percent. And now, fortunately, this is more of a chronic illness than a life sentence, thanks to the antiretroviral therapy that exists in screening kids. The complications that you need to know for your board. So the first one is going to be pneumocystis. That's the most common. It usually occurs within 5 to 7 months of infection. Lymphoid interstitial pneumonitis is second most common. Typically, we only see that in infancy. And then recurrent bacterial infection is the third most common. We typically give the polysaccharide and pneumococcal vaccine when they turn 2. And then progressive multifocal leukoencephalacia is pretty uncommon now in the era of antiretroviral therapy. All right, one of the other choices, right, we looked for an RPR, so think about syphilis. So this is where maternal testing and treatment goes a long way in helping us determine what we do for baby. So, right, so whether the treatment was before pregnancy, if it was during pregnancy but greater than 4 weeks before delivery, or if it was less than that or had no therapy whatsoever. The manifestation of syphilis are somewhat non-specific, but some clues they'll give you hepatosplenomegaly, lymphadenopathy, and snuffle, so copious amounts of runny nose that have tons and tons of spirochetes in them. So if you're concerned about a neonate in your nursery who has syphilis, make sure you wear gloves because the secretions from the nose can have lots of spirochetes. Oftentimes, they'll have osteochondritis, and so they won't move one of the extremities, and that's where an X-ray is going to be helpful for you. We typically do non-treponemal testing, so RPR or VDRL, followed by treponemal testing for confirmatory test. And then we treat these kids sort of based off of whether or not it's proven or highly probable disease, which is where you give IV penicillin. And the key for syphilis, it has to be penicillin. So if you give these kids ampicillin for 2 days because you're ruling out sepsis or something, ampicillin does not count. You have to give them the full therapy with penicillin. Possible syphilis, when we do for possible when we do IM therapy, usually it's 1 dose, and then we follow these kids in clinic and typically repeating a RPR or VDRL, whichever they did in the hospital. Rubella, which we don't see very much anymore, but the board will like to maybe throw this in there. The things you're going to see with this particular illness is congenital malformations, mainly glaucoma or cataracts, which you'll see a picture of in just a second. CNS abnormalities, including hearing loss, and then cardiac dysfunction. So the most common is a PDA with or without pulmonary stenosis. The sooner the baby gets infected in utero, the more likely they are to have symptoms. Postnatal infection tends to have posterior or auricular lymphadenopathy, and then a rash that we'll see in just a second. And then they also have lesions in their mouth or in an anthem, which are the Forsheimer spots, typically a little bigger than petechiae. They occur in about 20% of the patients with rubella. So this is an infant with glaucoma that you could see in your nursery. This is usually going to be seen in the first trimester. This indicates that the baby was infected in the first trimester, and then postnatal rubella with a maculopapular rash. All right, so then CMV and toxo, right? So the T and the C. So both have chorioretinitis. Both have intracranial calcification, so they look quite similar. The differentiating aspects, one is that the calcifications for CMV are going to be along the ventricular circumference, whereas toxo calcifications are going to be everywhere. So you're going to see a much more widespread calcification pattern in toxo than you will in CMV. So typically they might give you mom exposure to cat or some other manifestation. The signs and symptoms are very similar to CMV. So outside of hydrocephalus, the symptoms are going to be quite similar, but hydrocephalus is the key that it's going to be toxo instead of CMV. Toxo is diagnosed using serologies, and the treatment is usually up to 12 months of age with pyrimethamine and sulfadiazine, and then we typically give leucovorin for pyrimethamine-induced neutropenia. The fetal risk is greater the longer, the later in pregnancy it is, but also the earlier it is, the more likely you're going to have more severe symptoms. This is similar to rubella. So the later in pregnancy, the infant is much less likely to be affected. For CMV, again, the most common, so this is what you want to think about first. It's more common when moms have a primary CMV infection than a non-primary CMV infection. Manifestations, again, very similar to toxo, but they're going to give a direct hyperbilirubinemia, which can be a clue for CMV. We now do PCRs, and that could be from serum, from urine, or from the buccal mucosa. The treatment for this is IV ganciclovir, or preferably PO valganciclovir. And we have to start this within 3 weeks of life. So congenital CMV has to be diagnosed pretty quickly. So if you think about it, if you wait till you get a hearing screen that's abnormal around 6 weeks of life, if that happens, and you do a CMV test that's positive, it's hard to say that that's congenital CMV because the kids get exposed to CMV quite often. We're all exposed to it quite often. We're all mostly serologic positive for it. And so it's hard to distinguish congenital infection from a postnatally acquired infection. And then the studies haven't shown any benefit of treating these kids outside of congenital infection after 3 weeks of life. And so it's very important to try to diagnose these kids as quickly as possible. And then another H, herpes, which we sort of already covered in an earlier case. All right, we'll move on from TORCH and do our next case. A 9-year-old fully immunized male presents with 2 to 3 days of fever, accompanied by worsening headache, photophobia, and neck pain. A temperature of 102.1, heart rate 90, respiration is 18, a blood pressure of 105/70. Any movement of the neck causes pain, and he keeps his eyes closed during the exam. He follows commands, but does so slowly or after repeated requests. No oral lesions, auscultation is unremarkable, with no rash or arthritis. The next best step in management is A, a CT of the head with and without contrast, P, PO steroid, C, a neurology consult, D, lumbar puncture, or E, a blood culture. All right, so the answer is D, a lumbar puncture, right? And most got that. So the second most common answer was the CT head with or without contrast. So unless there's a focal finding, or a patient is in a coma, or they have documented papilledema, there's no real indication to do a CT before you do a spinal tap. So this is why, in this case, spinal tap is first. We don't do steroids because this kid is immunized, so we're not worried about Haemophilus influenza serotype B causing meningitis. A blood culture can be helpful, especially if you can't get the LP for whatever reason, and before you start antibiotics to try to get a pathogen. But for this particular step, it's lumbar puncture. So sort of continuing on this theme, a 9-year-old fully immunized male presents with 2 to 3 days of fever accompanied by worsening headache, photophobia, and neck pain. You get that CSF, and the white count has 5,300 whites, red blood cells of 250, a glucose of 3, and protein 99. The Gram-stain shows gram-positive cocci in pairs. You want to start which anti-infective regimen? IV Vinc, IV ceftriaxone, IV meropenem, IV cefepime, and IV clindamycin, or E, IV Vinc, and IV ceftriaxone. Right, so E, IV Vinc, and IV ceftriaxone. Okay, so I chose these. So please don't get frustrated if you're getting some of these wrong. Like, there's a reason I put these cases in here, and a lot of it had to do with when I took my board exam and didn't pass it the first time. I did not think of the nuances for this, and so after 14 years of teaching, this is what I see most students and residents get mixed up with in terms of what we use to treat and why we do it, because that's an important piece of why you choose these answers. So please don't get frustrated that if the majority of people got the different answer that I got. I'm trying to tell you why this is the answer. So we don't do IV Vinc by itself, right? So the chances are this is gram-positive cocci in pairs, right? So what bug is this? So it's not staph. Right, so Staph aureus, this is great. Staph aureus does not have a tropism for the central nervous system. Unless you have a shunt, unless you have some sort of hardware in the central nervous system, it's not going to cause a meningitis. So we don't use Vinc for Staph aureus CNS infection in an otherwise kid who looks like they have bacterial meningitis. Right, this kid has pneumococcal meningitis. Right, so that's the most common typically we see in younger kids, and we use Vinc and ceftriaxone. The 43% of you who chose B, right, that's going to be, ceftriaxone is probably going to do the work, right? Chances are ceftriaxone is going to cross the blood-brain barrier better than Vinc. It's going to be more active against strep pneumo, and so that's correct. However, there is a chance, a decent chance, depending on where you live, of strep pneumo being ceftriaxone resistant, and you're not going to know that empirically. And when you have a kid with a CNS infection, you don't take that chance. Right? If they have a mild pneumonia, you could take that chance because the ceftriaxone gets to the lung really well and you can overcome some resistance with that. But when it comes to CNS disease and the blood-brain barrier not allowing your antibiotics in to try to help the infection that got in, you want ceftriaxone to cross it and hopefully treat it. But if it's resistant, you won't vancomycin because you're not going to have vanc-resistant strep pneumo for the most part, especially on your boards. So you do vanc and ceftriaxone empirically for this kid. We don't do meropenem because you don't need it for strep pneumo. If you had a kid who had gram-negative rod meningitis, you could do it, especially if they are immunocompromised or recently on antibiotics for another reason, but you typically don't need that for this. And D, cefepime, you don't really need it for Pseudomonas coverage in this case, and then Clenda doesn't cross the blood-brain barrier, so you don't use Clenda at all for any sort of CNS infection. Okay, let's sort of continue in this line of questioning. A 9-year-old fully immunized male presents with 2 to 3 days of fever accompanied by worsening headache, photophobia, and neck pain. The white count shows in the CSF of 5,300, a red count of 250, glucose 3, protein 99. Gram stain shows gram-negative cocci in pairs. You want to start which anti-infective regimen? A, IV vanc, B, IV ceftriaxone, C, IV meropenem, D, IV cefepime and IV Clenda, or E, IV vanc and IV ceftriaxone. All right, so the answer is B, IV ceftriaxone, right? More than half, and you got that, right? So the reason this one is so gram-negative diplococci, right? So what is this? Right, meningitis, right? Neisseria meningitis, right? So on the boards, the gram stain is never wrong. So when the gram stain tells you gram-negative diplococci, it's really gram-negative diplococci. In real life, it's a human interpreting the gram stain. Maybe it's gram-positive cocci, who knows? But for the boards, they're correct. So this is telling you this is Neisseria meningitis, and the drug of choice for that empirically for CNS disease is ceftriaxone. All right, sort of the last one. A 9-day-old fully immunized male presents 2 to 3 days of fever accompanied by fussiness and decreased feeds. The temp is 102.1, heart rate of 110, respiration is 28, blood pressure 105/70. Any movement of his neck causes pain. His anterior fontanelle is slightly bulging. No oral lesions. Auscultation unremarkable with no rash or arthritis. CSF has a white count of 5,300. Red blood cell count is 250. Glucose at 3. Protein at 99. The gram stain has no organisms seen. Which anti-infective regimen is most appropriate? A, IV vanc, B, IV ceftriaxone, C, IV piptazo, D, IV amp and IV ceftaz, or E, IV vanc and IV ceftriaxone. All right, D, IV amp and IV ceftaz, which most of you got correct. Good. That's right, so this is a 90-year-old, so we worry about a few particular infections we'll talk about in 1 second. So vanc would not be an option. We're really worried about strep pneumo when we're talking about vanc. Ceftriaxone, again, would be better for strep pneumo and Neisseria meningitis. We also tend not to give newborns ceftriaxone because of the displacement of bilirubin and the biliary sludge that can happen. Piptazo does not cross the blood-brain barrier very well, so we tend not to use piptazo for CNS infections. And then IV vanc and ceftriaxone, again, we use that empirically for the routine bacterial meningitis in older kids. So when we talk about bacterial meningitis, age matters. If they're less than 3 months of age, we talk about group B strep, we talk about E. coli, Listeria, and strep pneumo. 3 months to 10 years of age, strep pneumo, Neisseria meningitis. And then when you get to 11, it switches. Neisseria becomes more common. When you think about gram-negative rods, especially in the newborn period, if they give you Enterobacter as a bug or Citrobacter as a bug, you have to think about a brain abscess. While all gram-negatives and really any bug can cause brain abscess when they cause CNS infection, those two in particular, Citrobacter and Enterobacter, you want to think about, if they say, what's your next step in management, you want to do an ultrasound of the head or a CT of the head or an MRI of the head to look for a brain abscess, because those two are notorious for causing brain abscesses. On the exam, your gram stain matters, right? So gram-negative pleomorphic bacilli or coccobacillus, right? This is thinking about Hib or H. influenza serotype B. That's where you give ceftriaxone and steroids. That's really the only time on your board you're going to give steroids for bacterial meningitis. Gram-negative rods, again, this is where ceftriaxone will likely be helpful, but if they're immunocompromised or a high risk otherwise or exposed to recent antibiotics, you want to do meropenem because it's very broad. And then gram-positive rods, we usually use AMP and third-generation cephalosporin, usually cefotaxime, but we don't seem to have that anymore, so we'll use Ceftaz. All right. So continuing on the meningitis line briefly, a 16-year-old female with Neisseria meningitidis meningitis is clinically stable. Which of the following persons should not be provided post-exposure prophylaxis? A, her boyfriend. B, her sister with whom she shares a bathroom. C, her aunt staying with the family for the past week. D, the resident who admitted her. Or E, her friend with whom she recently shared a flight from China. All right, so D, the resident who admitted her. And we'll see y'all got that correct, right? And so the reason is for high-risk individuals, right? So when we talk about household contacts, right? So that's the sister. Direct exposure to secretions. 16-year-old female has a boyfriend, so likely the boyfriend may have been exposed to her secretions. Living in the same dwelling, so that would be the aunt, and then the 8-hour flight seatmate, which was her friend. Yeah. So the resident who admitted her, unless the resident intubated her without a mask and got secretions, that's the only time that resident would need to get post-exposure prophylaxis. The drug of choice for prophylaxis is rifampin, and that is really for all kids under 18. If they give you a teenager who is pregnant who had exposure, that's where you would give ceftriaxone. And then Cipro is another option, usually the third option, as an acceptable alternative to rifampin. Okay, so case 14. A 14-year-old immunized female presents to the ED for evaluation of altered mental status. She has fever 4 days ago. She developed fever 4 days ago, just a day after her school release for the summer. Mom notes that the patient has made comments that did not make sense or seemed intended for someone who was not there. She's been sleeping a lot more the last 3 days, and this morning she was not able to carry on the conversation. Exam has a temperature of 100.9, heart rate 86, blood pressure 115/70, and 96% on room air. She is somnolent and will not follow commands consistently. She has no rash and no papilledema. Her white count in her CSF is 4. Her glucose is 61 with a serum glucose of 87. Her PCR panel, which includes herpes and varicella zoster, is negative. Her CBC and CMP are normal. The most appropriate anti-infective to initiate is A, IV Vanc, B, IV ceftriaxone, C, IV Piptazo, D, IV acyclovir, or E, no anti-infective treatment at this time. So E, no anti-infective treatment. Wow, 73% of y'all would be willing to not put this kid on anti-infective therapy. I mean, that's the answer, but it scares the heck out of me to do that, right? But so IV Vanc and IV ceftriaxone, right? This kid does not have bacterial meningitis, right? So white count was normal, the glucose was normal, the protein was, so kid does not have bacterial meningitis, right? Just remember, and this kid was not pre-treated, right? So when we talk about pre-treating kids who might have bacterial meningitis, well, yes, there's a slight chance that pre-treatment will sterilize the CSF. You got to remember, there's not a great chance that the PO antibiotic or even the PO antibiotic is not going to cross the blood-brain barrier. IV obviously will a little bit. So it might sterilize the CSF culture, but it's not going to cause the CSF white count to become normal quickly, and it's not going to cause the CSF glucose to become normal quickly. So those are clues that even if someone is pre-treated, if they have a white count of 10,000 and no glucose, that's bacterial meningitis. Even if they were pre-treated and the culture is negative, that's bacterial meningitis. For this kid, everything looked okay, right? So that would be no anti-infective therapy at this time. So the clues really are the CSF profile. It's not herpes. So sometimes your herpes simplex PCR on the panel can be, there are reports of it being negative very early in the course of illness. And so if this kid had been ill for 4 hours and they came in and got an LP and that was herpes PCR negative, but you really suspected herpes because they just had a cold sore for the first time, or they have abnormalities on the MRI and the temporal lobes, or they have pledge on the EEG, then you repeat an LP and do a HSV PCR in a few days. But this kid had symptoms for at least a few days, and so it should be positive, right? And then sometimes the boards will give you clues, either clues in terms of timing of season or geography, and we'll talk about that in just a little bit, right? So the summer gives you a clue that this could be a rickettsial disease. This could be an arbovirus, right? So mosquito-borne illness, and that's what it's trying to get you to think about in terms of no anti-infective therapy is needed at this time. And the CBC being normal sort of makes rickettsial disease less likely, as they'll typically have anemia or low platelets. So when we talk about encephalitis, so when they looked at the California Encephalitis Project, the majority of the time they could not identify a pathogen for the patient to have encephalitis, and when they were able to identify it, it typically was a viral illness. Sometimes it could be post-infectious, and that would include acute disseminated encephalomyelitis, which we're not going to get into in this particular talk. Oftentimes it's non-polio enteroviruses and part echovirus. Sometimes it can be HSV, like we talked about, and the treatment for that is acyclovir at 10 mg per kg per dose, as opposed to neonatal HSV therapy, which we use 20 mg per kg per dose. CMV can cause meningoencephalitis, especially in immunocompromised patients. Mycoplasma can do it. Historically, it's thought that it was an immune-mediated process, but there are case reports of PCR positivity from CSF, but it's still not clear if it's the invasion of the microbe or the immune response to it. Similar to Bartonella, it's typically going to be an immune-mediated response for Bartonella. And HHV6 is a pretty common cause of meningoencephalitis in kids. And for the most part, you don't need to treat those kids. We mentioned arboviruses, so thinking about California lacrosse virus that can cause headache, nausea, vomiting, some disorientation. West Nile virus, malaise, headache, eye pain, nausea, vomiting. Most are asymptomatic, and neuroinvasive disease occurs rarely. So we think about geography when it comes to this, but first, West Nile, we typically diagnose it. First, it has to be to the community, so your public health department is going to be very helpful in this situation. They're going to give you clues that it's starting. We typically do an IgM antibody of both the serum and the CSF, where CSF is typically more specific for an acute CNS infection. And then after the disease is well established, usually in the community, that clinical diagnosis is usually straightforward. So we talk about California lacrosse. Oftentimes it's going to be, they're going to give you somebody in Ohio and Tennessee or North Carolina. It's kind of sort of in that area. So that's California lacrosse. Think about West Nile. And it sort of depends on the season, on the year, but for the most part, it's going to be sort of along this area here. I don't know, is that considered the Midwest I think distance into the Midwest, this seems more westerny, but this is the West. I don't really know where Midwest is anymore. So along that corridor. Eastern equine, so think about eastern equine usually touching the Mississippi River or just east of the Mississippi River. The thing that's concerning about eastern equine is the morbidity and mortality associated with it tends to be really high. Usually of all the arboviruses, this is the one you certainly do not want because it is pretty terrible. So things that could be on your boards are chikungunya and Zika viruses that are both mosquito transmitted. No vaccines, no antivirals in place at the moment. There are nonspecific symptoms, oftentimes with arthralgia and myalgia especially, although most of the time they are asymptomatic. They're going to give you a travel history for these patients to think about chikungunya or Zika virus. Chikungunya is usually going to be somewhere in the Caribbean. Zika is going to be somewhere in South America. But don't forget, congenital Zika can happen. So if they give you a case that looks like congenital CMV or congenital toxo, especially with intracranial calcifications, but doesn't quite fit, and they tell you mom just immigrated from Honduras, think about congenital Zika. If they give you an absence of the corpus callosum, think about congenital Zika. So when we talk about other CNS infections or encephalitis, we don't want to forget rickettsial disease. So just think about geography. Usually when the boards give you geography, it's a clue to think about something in particular. Right, so Rocky Mountain spotted fever is going to be in your Oklahoma, Arkansas, Missouri area or mid-Atlantic on the East Coast. Ehrlichia, which again we'll talk about later when we talk about rickettsial diseases. Again, similar Oklahoma, Arkansas, Missouri, a little bit in where we are now in the Maryland, Virginia area, and anaplasma. Another rickettsial disease, you're going to usually give Wisconsin or Minnesota or Maine are going to be your clues for that. And Ehrlichia and anaplasmosis are quite similar, but if they give you they should give you geography to tell you whether it's anaplasma in the north or Ehrlichia in the south. All right. Case 15, a 22-month-old immunized female presents with 2 days of fever to 102. Parents report some runny nose for the past week, but deny any other respiratory symptoms. She did have some loose stools earlier in the week that have since resolved. Parents also report that her urine has had a strong smell since yesterday. Temperature on exam is 101.1, a heart rate of 110, respirations 18, and a blood pressure 96/60. No effusions are noted on otoscopic exam. Postioropharynx is clear, an unremarkable auscultation. Her abdominal palpation does not reveal any focal tenderness. A GU exam is unremarkable, and there's no arthritis. A UA shows protein of 10, 0 to 5 whites, 0 to 5 reds, no leukocyte esterase, and no nitrate. What would be your next step in management? Is it A, a urine culture, B, a blood culture, C, a rapid strep, D, give IM penicillin, or E, supportive care? All right, E, supportive care. Right, so most of y'all got that. Okay, so the next favorite answer was A, urine culture. Right, so there's no indication to do a urine culture in this patient. Right, so yes, they have fever, but they have no pyuria on the urinalysis. And so unless they have pyuria on the urinalysis, you don't need to do a urine culture. So urine culture will not be indicated. The patient is immunized, so a blood culture is less needed, especially how well they look. A rapid strep test. So while this could be streptococcosis, which is a group A strep causing what looks like a URI, it tends not to lead to rheumatic fever. And so we don't need to do a rapid strep for these kids, especially kids who are less than 4. And then IM penicillin, you need a diagnosis of group A strep pharyngitis first before you just give them IM penicillin. And it's also hard to find right now, IM penicillin. So yeah, so the answer is E, supportive care. All right, let's sort of continue. So this is question 15A. Obviously, there's a 15B. A urine culture accidentally gets sent and returns with 50,000 CFU per mil of E. coli. What would be your next step in management? A, IV ceftriaxone, B, oseltamivir, C, IV TMP-SMX, D, PO Clenda, or E, supportive care? All right, E, supportive care. Most of you got that, right? So IV ceftriaxone would be fine for a bona fide urinary tract infection for kids who are admitted to the hospital, which is not this kid. Ceftonir is a fine choice when you have a bona fide UTI you want to treat in the outpatient setting. Ceftonir would be a fine choice. It would cover E. coli and Kleb and whatnot. But this kid does not have a UTI, right? Just because you have a positive urine culture, this kid would have asymptomatic bacteria, right? Again, no pyuria. The guidelines say you have to have pyuria and a positive urine culture. And this kid only has a positive urine culture. That shouldn't have got sent in the first place. And so we wouldn't use therapy for this kid. IVT and PSMX, again, it's bioavailable. So there would be no real indication to do IV. TMPSMX, we would want to give PO. PO Clenda does not cover gram negatives, and the most common cause of UTI is E. coli, which is a gram negative, so there's really no indication to give Clenda in a kid with concern for UTI. So it would be supportive care. The only time we get worried about asymptomatic bacteria is in teenagers who are pregnant when we treat those particular individuals. Okay, we have a 22-month-old, case 16. A 22-month-old immunized male presents with 2 days of fever to 102. Parents report some runny nose for the past week, but deny any other respiratory symptoms. He did have some loose stools earlier in the week that have since resolved. Parents also report that his urine has had a strong smell since yesterday. Exam shows a temperature of 101.1, a heart rate of 110, respiration 18, blood pressure 96/60. No effusions on otoscopic exam. Posterior oropharynx is clear, unremarkable auscultation. Abdominal exam is clear. GU is unremarkable, and no arthritis. The UA has 10 of protein, 10 to 20 whites, 0 to 5 reds, and small leukoesterase with no nitrate. What would be your next step in management? A, urine culture, B, a blood culture, C, rapid strep, D, IM penicillin, or E, supportive care? A urine culture. All right, so 91%, right? So again, this kid now has pyuria, in which case the next step is to do a urine culture. Okay, so urine culture grows 100,000 CFU per mil of E. coli. What would be your next step in management? A, IV ceftriaxone, B, PO-ceftonir, C, IVT and PSMX, D, PO Clenda, or E, PO Cipro? Right? B, PO-ceftonir. Excellent, right? So this kid did not admitted to the hospital, so you don't need to give IV ceftriaxone. If the kid was admitted and needed to be on IV therapy, ceftriaxone would be a reasonable choice. And then PO-ceftonir would be good. Second generation cephalosporin like ceftriaxone would be fine as well. Again, we don't do IVT and PSMX. We would do PO-T and PSMX if we needed to. Depending on your antibiogram and how resistant E. coli is to T and PSMX would be the determination whether or not you can use it empirically or not. If your E. coli tends to be more than 20% resistant in your location, you typically wouldn't want to use T and PSMX empirically for UTI. If it's less than 20%, you should be okay. PO-Cipro can be used for UTIs, but it is not the first line. It typically is because you have a multi-drug resistant organism or the patient is intolerant or allergic to the other options you can give. So when we think about these cases, right, so the strong smell, it's not a very specific sign or symptom. Urine can have a strong smell for a number of different reasons. It doesn't mean there's an infection. And for the first case that had no pyuria, that's why we didn't do anything with it. In the second case, case 16, right, we gave you a male, even though females have a 2 to 4 times higher prevalence. So remember, males less than 1 year, except when they're uncircumcised, they have a much higher risk of UTI, and the girls usually less than 4. So UTIs, right, most commonly UTIs are due to E. coli or Kleb or other gram-negative. A gram-positive enterococcus can do it. So if you have a kid who is on cefuroxime or cefdinir and not getting better from a UTI standpoint, and you don't have a culture back, consider switching therapy to enterococcus coverage, right? Because remember, none of the cephalosporins have enterococcus coverage. Enterococcus is only really covered by Amox or AMP if it's Enterococcus faecalis, and then sometimes if it's VANC-resistant enterococcus, we need something like Nasalid. Staph saprophyticus is another gram-positive. Think about that in your adolescence. For your first UTI in kids, you want to get a renal ultrasound. You do not need a VCUG after your first UTI. You only get it if your renal ultrasound is abnormal or you have recurrences of UTIs. All right. Question 17. A 10-year-old male presents with left neck swelling for 2 to 3 days and fever at home. The affected area is 3 by 2 centimeters, red, fluctuant, and tender to palpation. He has had no animal exposure. The most likely etiology of his disease is A, nontuberculous mycobacterium, B, strep pyogenes or group A strep, C, Bartonella henselae, D, Epstein-Barr virus, or E, Yersinia pestis. All right, so the answer is B, strep pyogenes, also known as group A strep. Most of y'all got this. The probably the more appropriate answer had it been given would be Staph aureus, because that's going to produce more fluctuants than group A strep. But of the options given, group A strep is more likely. We're not going to go through all these just yet, because this is a string of questions that are all sort of similar. So for this kid was group A strep. And we'll go through these in just a few minutes. So question 18, a 10-year-old male presents with left neck swelling for 2 to 3 days and fever at home. The affected area is 1 to 2 centimeters, but it is not red, fluctuant, or tender palpation. And he has shoddy nodes adjacent to it. He has no animal exposure. The most likely etiology of his disease is A, nontuberculous mycobacterium, B, strep pyogenes, C, Bartonella henselae, D, Epstein-Barr virus, or E, Yersinia pestis. All right, so Epstein-Barr virus for this particular kid, which most of y'all got. Again, so this more like a mono-like illness. We could have given you more symptoms like tonsillitis or a big spleen on exam, but we didn't. So just again, trying to let you see the nuances of why one answer is the answer versus another. So we'll continue in this flow for question 19. A 10-year-old male presents with left neck swelling for 4 to 5 days and fever at home. The affected area is 3 by 2 centimeters, red, and tender to palpation, but not fluctuant. Pet kitten was acquired about a month ago. The most likely etiology of his disease is A, nontuberculous mycobacterium, B, strep pyogenes, C, Bartonella henselae, D, EBV, or E, Yersinia pestis. All right, C, Bartonella henselae. Right, so there was a little bit of a clue in this one, right? So this gave you a pet kitten causing some adenitis. So Bartonella would be the answer for this one. And then we have a 10-year-old male who presents with left neck swelling for 2 to 3 weeks with no fever at home. The affected area is 4 by 3 centimeters, purple and mildly fluctuant, but not tender palpation. He's had no animal exposure and no changes with 2 rounds of different antibiotics. Most likely etiology of his disease is A, nontuberculous mycobacterium, B, strep pyogenes, C, Bartonella, D, EBV, or E, Yersinia pestis. All right, so this is NTM, or nontuberculous mycobacterium, or atypical mycobacterium. The clue for this one is that it's sort of purple. It tends to bother the parent more than it bothers the kid. We tried antibiotics, and it didn't seem to have any effect. right? So whether or not that was because the wrong antibiotics were chosen, or because it's a non-tuberculous mycobacterium infection is more likely. So usually it's going to be prolonged lymphadenopathy or lymphadenitis for this particular bug. So when we talk about adenopathy, Staph aureus and group A strep tend to cause more adenitis. So that's the red, fluctuant, angry, acute infection, and that's going to be group A strep or Staph aureus. Non-tuberculous mycobacterium we'll talk about next, and these others. So non-tuberculous mycobacterium is often going to be Staphylococcus, MAI, or abscessus, usually going to be the cervical node. Diagnostic is also curative. So really it's excision. So excise the node, you'll be able to do a sample, you'll be able to do culture of it, but also that's also curative for the patient. Sometimes if it's necrosed quite a bit, our ENT friends will ask us to do antibiotics for a little bit, and then they'll go in and do excision. So if we do that, we'll typically use a macrolide, whether azithro or clarithromycin, and rifampin for a certain amount of time. Again, we typically have to treat these for a little while meaning at least a few months, because they tend to be slow-growing bacteria, and so we need to treat them for a while longer. Leprosy is also another non-tuberculous mycobacterium. You might be seeing it in the news in Florida. We're usually going to get an exposure history, and that's going to be in Southeast Asia more commonly, which is home to 65% of the world's leprosy. And that's usually a diagnosis, usually a skin biopsy or skin sampling, and you see acid-fast stain of that. And then Mycobacterium marinum, they're going to give you a clue that these are cleaners of fish tanks. There's going to be skin ulcerations that go along the lymphatic tracts. We'll talk about something else that does something similar later on. It's going to be sporotrichosis. And so think about Mycobacterium marinum and sporotrichosis presenting similarly, but the board will give you an epidemiologic clue as to which one it is for the most part. Bartonella henselae, right, another cause of adenitis or adenopathy. It's usually cat bites or cat scratches that can be carried by cat fleas. It's usually the flea feces that contaminate wounds when you're inoculating them. We see this a lot in clinic for FUOs or fever of unknown origin or fever without a source. Regional adenopathy. We can cause meningoencephalitis or encephalopathy. We think it's an immune-mediated process. We also have, we diagnose it through serology in the blood, so IgG and IgM. We can do PCR. We typically don't do that in the blood because they're oftentimes not bacteremic when we see them. We do PCR oftentimes from the tissue. So whether it's from the adenitis tissue, skin tissue, whatever tissue we have, we'll send that for Bartonella PCR. The treatment usually is none. Even though it's a bacteria, it tends to sort of self-resolve. But if we have neuro involvement, including opto, we'll typically use doxy with rifampin and steroids. So this is our friendo with left axillary adenopathy. Again, usually it's not going to be in the neck or cervical adenopathy. It's usually going to be axillary or inguinal adenopathy for the most part. Yersinia pestis, right? So this is the one answer that was not chosen. So this is right. This is plague. So bubonic is adenopathy that separates, and we'll see an illustration of that in just 1 second. It can present in septicemia with multi-organ failure and DIC, or the pneumonic manifestation, which is very contagious with coughing. Some keywords you might see when they're looking for it in terms of staining are fried egg colonies on the growing auger, or a safety pin appearance on staining. The treatment tends to be an aminoglycoside, streptomycin or gentamicin. If it involves the CNS, we typically use chloramphenicol and levofloxacin. And this is a bioterrorism threat, so we always want to let your lab know if you're concerned that a patient might have Yersinia pestis. And unlike anthrax, there is this person spread with the pneumonic manifestation. So this is plague, the buboes that are seen in the inguinal area that oftentimes separate. And this is where we see Yersinia pestis, again, sort of in the four corners and the West Coast. And you have this one little person who got it in Chicago somehow, and he traveled and came back. But again, this is where geography is going to help you, right? So this is geography for Yersinia pestis, geography for tularemia, right? So you think about this in Arkansas, Missouri, Kansas, Oklahoma area, which looks similar to Ehrlichia and Rocky Mountain spotted fever. So I always think about geography. So speaking of tularemia, the other epi clues they're going to give you are usually rabbits or rodents. You're going to have ulceroglandular disease. You can get respiratory manifestations if you inhale quite a bit at one time, although that's less common. We diagnose these with serology, so IgG and IgM, or similar Bartonella. If we can get a sample of whatever the adenitis is, we can do a PCR. The treatment is gentamicin or Cipro. And again, this is also a bioterrorism concern. So you want to alert the lab. This is our friend from Arkansas with posterior adenitis on his neck due to tularemia. Actually, I don't know he's from Arkansas. I just sort of wanted to reference Arkansas because we see it a lot there. And ocular glandular disease we'll see as well. Non-infectious etiologies of lymphadenopathy. So just because you have a large node doesn't mean it's an infection. Just because, so I have a colleague, Jeff Deo, who is 20 years older than me, but he's going to be talking, I think, tomorrow. We apparently look similar, so he looks good for his age. But just not everything that is lymphadenopathy is cancer either, he'll tell you. So we often have conversations about if it's infectious or non-infectious, so or oncologic or non-oncologic. So just remember there are non-infectious etiologies, so reactive adenopathy, Kawasaki disease, which we're not going to go into detail here, but remember Kawasaki disease, you have to have at least 5 days of fever, and then there are 5 major manifestations, right? So there's conjunctivitis, right? So non-draining conjunctivitis. There's mucous membrane changes. There's rash. There's peripheral adenopathy, and then there's peripheral edema. And unilateral adenopathy. And then it's very often unilateral adenopathy. If you have bilateral adenopathy, that's suggestive more of a viral process. Sarcoidosis, and Jeff Deo's favorite topic, oncologic. A 12-year-old female steps on a dirty nail with cow feces on it. Subsequently, her dog licks the foot. She's had 4 tetanus immunizations in the past, and her last immunization was 6 years ago. Which of the following, if any, does she require? A Tdap only, B, a DTaP only, C, a Tdap and tetanus immunoglobulin, D, a DTaP and tetanus immunoglobulin, or E, no further immunization at this time. So a Tdap only. So most of y'all got this, right? So I guess we would all agree that this is not a clean wound, right? A clean wound, right? So this is a dirty wound. So Tdap only. So it's not C or D, which has immunoglobulin, because the kid has had at least 3 vaccines. So anytime, regardless of how dirty it is, if they have had at least 3 tetanus vaccines, they do not need immune globulin. And then DTaP, because she's 12 years old, so she's older than 7, then Tdap is the preferred vaccine. Less than that, you would give DTaP. And then obviously, no further immunization at this time is not the right answer because it's been at least 6 years since her last immunization. We'll talk about this, right? So if the wound is clean, and you need this, you're going to have like one question on this, but it's probably going to be on every board exam until whenever. But if the wound is clean and the immunizations are up to date, meaning less than 10 years since the last one, you don't need any treatment. If the immunization has been at least 10 years ago, then you want to give DTaP. If they're less than 7, you give DTaP. If they're at least 7, you give Tdap. Right? If the wound is clean. If the wound is dirty, but their immunizations are up to date, and it's been less than 5 years since their last tetanus vaccine, then you give no treatment. If it's been at least 5 years, then you give Tdap or DTaP depending on their age. Remember, Tdap is 7 and up. If the wound is dirty and either they've had less than 3 vaccines or you have no way of knowing how many tetanus vaccines they've had, then you give the appropriate vaccine, DT, AP, or Tdap, depending on their age, and immune globulin. That's the only time you give immune globulin. So the things that we can see with tetanus include epistaxis, which fortunately we don't see very much anymore. All right, case 22. A 12-year-old male with tuberculosis contact history presents with a productive cough that started a few weeks ago. He has no fever and no rash. A T-spot for TB is positive. The next management steps would be A, start isoniazid for 9 months. B, start a course of amoxiclav. C, do a chest x-ray and sputum for AFB or acid-fast bacilli ×3. If both are clear, start INH for 9 months. D, do a chest x-ray and sputum ×3 for AFB. If either are positive, you then do isoniazid for 9 months. Or E, perform a tuberculin skin test in 2 weeks to be sure that the T-spot was not a false positive. All right, so C, x-ray, sputum, if both are clear, start INH for 9 months. So many of you got that. So we'll go through each one. So start INH for 9 months. A few people put that. So the key for this one, though, is you need to determine if this kid has a latent TB infection, meaning they have the germs in their body, they have a positive T-spot or quantiferin gold, but they have no signs, no symptoms, and no abnormal chest x-ray. Right? So for this kid, you don't know if the cough is related to TB or if it's related to a viral or lower respiratory tract infection or what. So in this case, you need to determine infection versus disease before you start any therapy at all. So this is why it's C, you do an x-ray and you do sputum for AFB. If both are clear, meaning they likely do not have disease, they have a latent TB infection, and you would then give them INH for 9 months. If you did an x-ray that's abnormal, or you did AFB stains on their sputum and they're abnormal, then that would indicate TB disease, and you would want to give them multi-drug therapy, not just monotherapy with INH. We don't do a TST because the IGRAs might be a false positive. It's actually the other way around. The IGRAs, the T-spot and the quantiferin gold, are much more specific for TB than a TST. And so you're more likely to have a false positive with the TST or a PPD, a skin test, than you would with the IGRA, the blood test. So continuing on this, if this patient has an abnormal chest x-ray and positive AFB sputum culture, your treatment would consist of A, isoniazid and rifampin unless the resistance is greater than 0.5%. B, isoniazid, rifampin, pyrazinamide plus minus ethambutol. C, INH only. D, INH, rifampin, and ethambutol. Or E, none. I call the state health department to investigate. So the answer is B, INH, rifampin, pyrazinamide, plus minus ethambutol, which most of y'all got, which is great. Again, we do multi-drug therapy for this, not just INH and rifampin. INH only would be for latent TB infection. We wouldn't do INH, rifampin, and ethambutol. We would need to add pyrazinamide into that. And ethambutol is plus minus because oftentimes kids get TB from an adult. Actually, that's really the only way they get it. And oftentimes you're going to know the resistance pattern of the adult's TB. And if the adult's TB is pan-sensitive, then you don't need ethambutol. If you don't know the sensitivity pattern, then you often start with 4-drug therapy, including ethambutol. And the answer E, you would treat, but you would also call the state health department so they can investigate from a public health standpoint, right? The kid gets TB from an adult, so they need to figure out who the adult is the kid got it from. So the key here is that the 12-year-old male, so if this kid had just latent TB infection, meaning they had a positive quantiferin gold or T-spot, but with negative chest X-ray and negative sputums, they have a latent TB infection. You can either give INH daily for 9 months, or you can do INH and rifampicin once a week for 12 weeks. We have that option now. It tends to be better tolerated from a compliance standpoint. The TB test, T-spot TB is positive, again, much more specific for TB than a tuberculin skin test or a PPD. So MTB, the children get this from adults. We sort of make the argument that when we have kids in the hospital with presumed pulmonary TB, we worry more about the adults who are with them than we do about the kids giving caregivers or providers TB. Most kids have no signs or symptoms, and infants and adolescents are more likely to be symptomatic. So again, infection versus disease. So a primary TB infection usually results in a tuberculosis infection, aka latent TB infection, and most do not have active pulmonary disease with their initial infection. Disease can occur with primary initial infection, more commonly in adolescents, in infants, and in patients with HIV. This typically occurs as lower lobe disease, although the pulmonary disease can be months to years after the initial infection. TB can infiltrate the central nervous system. Any kid you have who is less than 2 who has pulmonary TB has to have a spinal tap because the likelihood of TB going to the central nervous system is very high. We can do an MRI that looks for basal ganglia or posterior enhancement. And oftentimes they'll have communicating hydrocephalus, and the prognosis for TB meningitis is pretty poor, oftentimes because of the delay in diagnosing it. So how do we test for TB, right? There are a few things, right? Old school skin testing, aka TST, aka PPD. We base our reading off of induration, not erythema. And so I was taught to close my eyes when I read the PPD result of my patients. That way I wouldn't be biased with the erythema that you see on the skin. So do it with your eyes closed. And again, it's the amount of induration. So basically, if it's 5 centimeters is the threshold. If you have a close contact with someone who has active pulmonary TB or TB disease, or you're immunocompromised. So that's if it's at least 5 centimeters. And then 15 millimeters for everybody who's 4 and up, if you're otherwise healthy. And then 10 is for folks who are from endemic areas or they're otherwise immunocompromised with prednisone, but not a very high dose of prednisone, or you're less than 4. So I try to remember it. 5 is close contact and immunocompromised. 15, everybody who's 4 and up. And then 10 for anybody else who might have a slight risk factor, including places from endemicity or a healthcare worker. Healthcare worker is 10. We now have these tests, the IGRA's interferon gamma release assays that are done on blood that are much more specific for TB than TSTs are. However, it cannot distinguish between a latent infection and active disease. That's where you still need to do chest X-rays and sputum cultures for that. Oftentimes we try to use them. I recommend them for everybody when I'm asked what TB screening test we should do, because we can do it in kids 2 years and up. It's very useful for kids who have had a history of BCG vaccine, because they're less likely to be cross-reactivity with the antigens from the BCG vaccine, bless you, and the quantiferon gold or T-spot. One trick the board sometimes like to do is give you a kid who has been in the United States since the age of 2, and they're now 12. They had a BCG vaccine, and they had a positive TST. And the thought is that they have TB. The answer is on the boards, the BCG vaccine is oftentimes a red herring. Don't think about it. Don't think about BCG as a source of positive TST or IGRA. That's not going to be the case. So the drugs we use for TB, INH, rifampicin or rifampin and pyrazinamide tend to be hepatotoxic. We don't do lab testing if they're just on INH monotherapy for latent TB infections, unless they have symptoms. When they're on multiple hepatotoxic drugs like INH and rifampin and pyrazinamide, we will do monthly labs, in particular LFTs. Ethambutol is not hepatotoxic, but it can cause a decrease in visual acuity. And then streptomycin can be oto and nephrotoxic because it is an aminoglycoside. All right, next case, AR23. A 14-month-old immunized male presents with fever up to 100.7, cough, and a runny nose with thick drainage. Had an episode of emesis. An exam reveals rhinorrhea and a clear posterior oropharynx. There is a 9-year-old sibling diagnosed with group A strep pharyngitis earlier in the week. The next best management step is A, supportive care and reassurance, B, a rapid strep test, C, a throat culture, D, PO-Amox, or E, IM penicillin. Right, A, supportive care and reassurance, right, which most of y'all got. Great. A rapid strep test and a throat culture aren't really indicated in a 14-month-old. Again, this is likely going to be streptococcosis, which looks like a really decent URI in a kid that can be due to group A strep, but doesn't lead to rheumatic fever or any concerns with that. So we tend not to need to do a rapid strep test or a throat culture in these kids. And certainly not an indication for antibiotics, as it's a self-limited illness. Even group A strep pharyngitis is a self-limited illness, but we treat to diminish the risk of sequelae. All right, let's do a next question. A 14-year-old immunized male comes in with fever to 102, cough and runny nose with thick drainage. 1 episode emesis, posterior oropharynx is red, and he has conjunctival injection. The next best management step is A, supportive care and reassurance, B, a rapid strep test, C, a throat culture, D, PO-Amox, or E, IM penicillin. All right, A, supportive care and reassurance. What do y'all think this kid has? Adenovirus, absolutely, right? Adenovirus, right? So which we don't do anything for. The cough, runny nose, when they have that's your clue that it's not group A strep pharyngitis. Strep pharyngitis does not have cold symptoms. Now, in real life, could they have group A strep pharyngitis and a URI due to a virus? Absolutely. But your boards are they have one thing, and so you go off the clues of that. Yeah, adenovirus. Fantastic. All right, let's do another 14-year-old who's immunized, who presents with fever to 102.9, left-sided neck pain, and shaking chills. 1 episode of emesis, exam shows tachypnea with shallow breaths, a slightly red posterior oropharynx, and a left jaw tenderness to palpation. The next best management step is A, a throat culture, B, flexion extension plain film of the neck, C, IM penicillin, D, IV ceftriaxone, or E, IV amsulbactam. All right, so E, IV amsulbactam. So we wouldn't do a throat culture. It's not really indicated in this particular situation, especially given the tachypnea and shallow breath. The left-sided neck pain and shaking chills suggest this kid is fairly ill. A flexion extension plain film of the neck would be good for a deep neck infection like a retropharyngeal or parapharyngeal abscess. That's not going to cause left jaw pain typically. It's also not going to cause shallow breaths often. IM penicillin wouldn't be good empirically, maybe once you get cultures back. IV ceftriaxone would be okay, but with this type of infection, you're usually going to have anaerobes as a causative agent for this, and this is why we would use IV amsulbactam because it has good gram-positive coverage, in particular group A strep, coverage. It would have some good gram-negative coverage and anaerobic coverage. We're not worried about Pseudomonas, which it doesn't. Sulbactam does not have Pseudomonas coverage, but we're really worried about group A strep, some gram-negatives, and anaerobes. So when we talk about abnormal pharynx, group A strep is the most common thing we see in pediatrics. So some of the sequelae are suppurative sequelae, right? So abscess or necrotizing fasciitis. And you can also have non-suppurative complications of group A strep pharyngitis, right? So acute rheumatic fever. As a reminder, rheumatic fever has the Jones criteria, right? The polyarthritis, erythema marginatum, chorea, carditis, and subcutaneous nodules. And then you can also have post-strep glomerulonephritis. Just remember that group A strep skin soft tissue infections can lead to post-strep glomerulonephritis, but not acute rheumatic fever. Group C and Group G strep, Archaeobacterium, Neisseria, and Fusobacterium necrophorum. You typically think in teenagers or young adults, right? So that's what this kid had. Fusarium necrophorum, right? So Lemire syndrome is what this kid had. You tend to think about it with Archaeobacterium and Fusobacterium necrophorum. So Archaeobacterium, right? It's a gram-positive weakly acid-fast bug. It's very similar to Group A strep in terms of producing a scarlet fever-like rash, but it doesn't have palatal petechiae or strawberry tongue. For Archaeobacterium, we typically use penicillin or macrolide to treat that. Fusobacterium is an anaerobic gram-negative pathogen and can cause pretty severe disease, including thrombi to the lungs and to the internal jugular. Neisseria we will see in teenagers as well. Typically, the treatment of choice for that is going to be ceftriaxone. And then Corynebacterium diphtheria, right? We don't typically see diphtheria anymore thanks to vaccines. Well, you'll typically see sort of a coating like this in the back of the throat. They're usually not going to be terribly febrile, but this is Corynebacterium diphtheria. We're not going to talk much, but other Corynebacterium species do exist, and they don't really cause issues unless they come from hardware, in particular central venous lines or catheters. Sometimes they can cause line infections with those. For Group A strep, the test of choice is going to be a rapid strep test. If that test is negative, you have to do a throat culture. The idea is that the throat culture is more sensitive than a rapid strep test, and so a rapid strep test negative needs to be followed up or reflexed to a throat culture. The treatment in order is penicillin. Penicillin is the drug of choice for this. Amoxicillin and amox you can give once a day. You don't have to give it twice a day for Group A strep pharyngitis. Cephalexin, clindamycin, and azithro. Azithro, there is resistance of Group A strep to azithro, so that's why it's the least choice. Group C and G strep, sometimes it can cause endocarditis or osteoarticular infections. Treatment for that is going to be penicillin. You isolate it from a blood culture. And then Archaeobacterium, we already talked about, you would also isolate from a throat culture. Neisseria, you could do a culture or do a nucleic acid amplification test for Neisseria and treat with ceftriaxone. Fusobacterium, again, which this kid had, we would use Amsulbactam or Piptazo or carbapenem initially. And then once you get ID susceptibility, sometimes you can go even down to just penicillin. We often do a CT scan of the neck and chest looking for thrombi, and oftentimes we get our hemoc friends involved. And then again, diphtheria, and we fortunately do not see it in this country as much. We do see it in countries who do have limited resources, and we usually use antitoxin plus either penicillin or erythromycin. So we'll go to question 26. A 6-year-old male presents with headache, fever, and sore throat. A rapid strep test is positive. You decide to prescribe antibiotics. The college student you are mentoring wants to know if this patient has the same strep that can cause hemolytic uremic syndrome, or HUS. You tell this astute young college student, A, yes, it's called Group A strep, or B, yep, it's called pneumococcus, or C, yep, it's called strep viridans, or D, you say, nope, pharyngitis is Group B strep while HUS is Group A strep, or you say E, nope, pharyngitis is Group A strep while HUS can be seen with pneumococcus. All right, so E, nope. Pharyngitis is group A strep, and HUS is pneumococcus. Right, so HUS can be, we often think of HUS with E. coli infections, right? But it can be seen with invasive strep pneumo infections, oftentimes with pulmonary disease. So always think about HUS, not only with E. coli, but with strep pneumo as well. So we talk about streptococcus. We've already sort of went over group A strep quite a bit earlier, and group B strep as well. Pneumococcal disease or pneumococcus, right? A very common cause of meningitis, very common cause of respiratory disease, not only otitis, but also sinus disease and lower respiratory tract infections. It can be a cause of bacteremia and osteoarticular infections. So one thing to remember, anytime you have a respiratory tract bacterial infection, the three amigos are strep pneumo, H flu, MCAT, whether it's ears, sinus, lower respiratory tract. H flu, MCAT, and strep pneumo. So you think about the drugs you need to cover those. If a kid has invasive pneumococcal disease with any of these, you want to consider sending him or her to your immunology friends for an evaluation. Up to a quarter of kids with invasive pneumococcal disease will have an immune deficiency, especially if they are already immunized. And so make sure you think about that and send them to immunology. Vierdens group strep, a broad group of strep species, will oftentimes cause infected myocarditis in kids who are risk factors and cause odontogenic infections. Okay, moving on. Case 27. A 15-year-old male presents with fever, chills, myalgias, and nausea, vomiting. He recently returned from a trip to Brazil where he visited family for a few weeks in the summer. Exam, he appears fatigued and pale, heart rate of 130, blood pressure 110/65, and a capillary refill of 5 seconds. He has a hemoglobin of 5.8, hematocrit of 19.8, and blood smear is performed, revealing. So remember, think about it, it has a season and it has location. Think about that. There's your smear. This patient has malaria due to which Plasmodium species? Right, so you probably already knew it was malaria, right? But the boards don't want you to know that. They want you to know specifically other questions regarding this. So which one does this patient have? Falciparum, Vivax, Ovale, malariae, or Knowlesi? All right, this is Falciparum, right? Most common, but also the idea that this is, right, so went to Brazil, fever, chills, myalgias, the cap refill being pretty long, and the hemoglobin make it severe malaria, which we're more likely going to see with Falciparum, and then the banana gametocyte that you saw is going to be Falciparum. So the smears we do for malaria, right, there's a thick and thin smear. The thick smear is a large amount of blood just to screen for the parasite, and the thin will be able to identify the species and also the degree of parasitemia. The severity of illness will depend on how we give therapy. Mild, they're usually able to take PO, and severe disease, they're going to have more organ dysfunction, including central nervous system, renal, and heme. The table sort of discriminating between which species do different things. A couple of things I wanted to highlight, right? So Falciparum, you're typically going to have a very high parasitemia, and you're going to have chloroquine resistance. Vivax and Ovale are the ones that can have liver relapse because of the hypnozoites in the liver, so you want to make sure they get primaquine. And then Falciparum is also going to have multiple parasites per red blood cell. In terms of prophylaxis, we try to do it for all types of malaria. Mefloquine once a week for 3 weeks is preferable, although you can start it at up to 1 week before you go. You want to use chloroquine if you're going to a chloroquine-sensitive area before arrival and continue for 4 weeks after leaving. You can also do doxy on a daily basis, or we can use atopiquone Prodranil once a day or two before you arrive, and then for a week after. Question 28. A 17-year-old presents with the following hepatitis B panel. The hepatitis B surface antigen is negative. The surface antibody is positive, the core antibody is positive, but the HBV DNA PCR is negative. The most likely explanation for these results is A, acute hepatitis B infection, C, a chronic hepatitis B infection, C, it's hepatitis B vaccine related, D, a false positive hepatitis B surface antibody, or E, a resolved hepatitis B infection. Okay, now hopefully, yeah. All right, so this is a resolved hepatitis B infection, which most of you got, right? So in order for it to be an active or acute infection, you need to have the surface antigen be positive. And with that being negative, in this case, you know it's not an active or chronic infection. If it's hepatitis B vaccine related, you're not going to have your core antibody be positive. So the fact that your surface antibody is positive, and your core antibody is positive with a negative antigen and a negative PCR means it's a resolved hepatitis B infection. So let's see if we can make sure we get this. A vaccinated 7-year-old presents with an ALT of 151 in the following hepatitis B panel. The surface antigen is negative, the surface antibody is positive, the core antibody is positive, and the DNA PCR is negative. The most likely explanation for these results is A, acute hepatitis B infection, C, a chronic hepatitis B infection, C, hepatitis B vaccine, D, false positive hepatitis B surface antibody, or E, resolved hepatitis B infection. All right, so hepatitis B vaccine, right? So you're going to get surface antibody positivity from the vaccine. It's not an active or chronic infection because the surface antigen is not positive, and your core antibody will be positive if it's related to an infection. So this would be a hepatitis B vaccine. So surface antigen infection, surface antibody is usually immunization. It can be due to infection as well, but if it's infection, then your core antibody would be positive as well. All right, case 30. A 13-year-old immunized male who just returned from summering in Martha's Vineyard in New England presents with progressive fatigue, myalgias for just over 1 week. He's had fever intermittently for the past few days, along with chills. Exam notes enlarged spleen and 2 erythematous circular patches. A thin smear is performed, and you see this. The arrow and the name will not appear on the actual, thin smear. The diagnostic evaluation for this patient should include what? A CBC with DIF, Ehrlichia IgG and IgM, Borrelia serology, P. falciparum PCR, or a blood culture. All right, so C, Borrelia serology. People thought maybe Ehrlichia as well. So locations, a clue, right? So they give you geography, right? So New England is in the northeast, Ehrlichia is going to be in the south, Anaplasma is going to be in the north. It's going to be in Maine, Minnesota, and Wisconsin, right? So you want to think about Borrelia infection of the Maltese cross is pretty classic for that. It's a tetrad that you can see with Babesia. Then patients can have both Lyme and Babesia is the Maltese cross. It's not going to be malaria, right, from a geographic standpoint, even though we're seeing malaria in Florida and Texas now, I think. It hasn't quite made it up to New England. So we'll talk briefly about Babesia, right? One of the predominant signs is going to be hemoglobinuria and emotional lability. So think about that in context of epidemiologic clues. The treatment is usually atovaquone plus azithromycin, or if severe enough, you can add exchange transfusion. Lyme disease, there are sort of 3 flavors of it. Early localized, early disseminated, and late disease. Early localized is going to be your erythema migrans at your tick site. especially in areas that are endemic to Lyme. Early disseminated, you're going to have multiple EMs. Several weeks after the tick bite, you're more likely to have systemic, non-specific symptoms such as fever, malaise, and arthralgia, and you'll often have cranial nerve palsies here. Late disease can be really late, a year or two after your initial infection. It's usually going to be large joint arthritis, and usually treatment of the early disease, either early localized or early disseminated, is going to prevent you from getting late disease. Usually the rash is diagnostic, especially again in areas of endemicity. Early disease without rash and late disease requires serology. So we typically do enzyme immunoabsorbent assays, followed by a Western blot, how we used to do HIV testing. We look at that. Treatment is usually doxycycline if they're 8 or older. Less than 8, we're going to do amoxicillin. And then early disseminated or late disease, we typically use doxy or amox, which is longer. If they do have central nervous system infections, because doxy and amox do not get into the blood-brain barrier very well, we typically do IV ceftriaxone. All right, case 31. A 10-year-old female presents with diarrhea for a few days after returning from a family summer trip where they were swimming every day at a neighborhood pool. She has no fever but slightly decreased appetite and no blood in the stool. CBC is unremarkable. Most likely to return positive as a causative agent in this patient is A, stool culture, B, Giardia antigen, C, a stool for overcystin parasites, D, a cryptosporidium antigen, or E, a C. diff PCR. All right, so this kid likely has cryptosporidium infection, right? So good, JR between Giardia and crypto for the most part. It wouldn't be a stool culture, right? This kid doesn't have fever. There's no blood in the stool, so you're not really worried about an enteritis or colitis. There's no eosinophils on the CBC, and so you think less likely roundworms. C. diff is not really an option. There's no risk factors for this particular patient. Giardia, you're going to be more in nature. You're going to see rivers and streams. That's really the main epi that's going to distinguish that from cryptosporidium. Cryptosporidium is going to be you went to your community pool and got diarrheal illness due to crypto. So that's really the main differences. So the stool antigen is the diagnostic test for cryptosporidium. We treat with nitazoxanide. And then Giardia is usually a DFA or an antigen test, and we treat with either Metro or nitazoxanide. Case 32, an 8-year-old female presents with rash. She does not have fever, but has been less active than usual. She's usually barefoot out on the beach in Alabama coast. Her rash gets slightly worse each day. It's similar to a rash her older brother had about 2 weeks ago, though his spread dramatically more each day. You got to remember that part. Just remember that part. Exam vitals are stable. Patient is afebrile and on a remarkable heart, lung, and abdominal exam. There's no lymphadenopathy, and the following rash is noted. The most likely pathogen causing her rash is A, Necator americanus or hookworm, B, Trichinella spiralis or trichinosis, C, Trichuris trichiuria or whipworm, D, Ascaris, or E, Strongyloides. All right, so A is the answer. All right, so this is hookworm. None of the others really have any dermatologic manifestations except for the second most common answer here, which is E, which is strongyloides. So let's go to this is 32A, so let's go to 32B. Since you knew what was going on with the 8-year-old, the mom asked about the brother who has since developed a non-productive cough and decreased oral intake. He complains of abdominal pain and mom notes constipation. Because the brother is not present, an exam is not possible. Though mom recalls the rash was initially on his feet and legs. After it turned brown, some pink-red streaks appeared on his buttocks. And remember this, the pace in which the brother's rash spread was greater than the sister's. So the most likely pathogen causing his illness is A, hookworm, B, trichinosis, C, whipworm, D, ascaris, or E, strongyloides. All right, so this is strongyloides, right? So this is his moves fast, right? So it tends to move the fastest of all the invasive parasites like this. So strongyloides is the answer for this one, especially over time. It involves other systems, including the GI system and respiratory system that the brother had that the sister did not. So when we talk about roundworms, aka nematodes, this is where we typically see our eosinophilia, peripheral eosinophilia. For ascaris, you're going to think about Loeffler syndrome, which is the migrating pulmonary infiltrates with a high peripheral eosinophilia, and they can get so voluminous in the intestine to cause obstruction. Pinworm or enterobius is the rectal itching, where you can do a pinworm paddle or a Scotch tape test and treat that with albendazole or mebendazole. A hookworm or Necator, that's the cutaneous larva migraines that our kid just had with weakness and fatigue. A whipworm, you'll have rectal prolapse is a big common clue, typically going to be somewhere in the south. And then trichinosis, you'll see calcifications in the muscle, and it's probably more frequent than we actually diagnose. So your parasites, sort of think about them in two ways. Your protozoa on the left, which we've touched on already for the most part, and then your helminths. The helminthic infections are the ones that are going to cause your peripheral eosinophilia. So that's usually a good discerning factor if you see those. Case 33. I promise it's going to be quick, hopefully. A 6-year-old immunized male presented with significant fatigue that followed a few days of fever along with swollen glands noted in his neck. Significant other was diagnosed with mono about a month ago. Exam reveals palpable spleen tip and bilateral cervical adenopathy, but no other adenopathy is noted. A rapid mono test is negative, a white count of 13,000, 70% lumps. A rapid strep test is negative, a throat culture is pending. The Epstein-Barr serology is performed, and you have an Epstein-Barr VCA or viral capsid antigen IgM that is negative. You have a VCA IgG that is positive, and EBNA, Epstein-Barr nuclear antigen IgG, that is positive. The best test to diagnose the etiology of his illness is A, an EBV PCR from the blood, A, group A strep PCR from a throat swab, C, an HIV PCR from the blood, D, a CMV IgG and IgM, or E, Borrelia IgG and IgM. All right, so CMV, IgG, and IgM. Right, so most people picked an EBV PCR from the blood. So it's pretty rare that we actually need an EBV PCR from the blood. That's going to come usually in your immunocompromised patients. So this kid has mono, right? Significant other had mono a month ago. Kid has what sounds like mono, but this kid's mono is due to CMV, not EBV. A group A strep PCR from the throat swab is usually not necessary. Again, rapid strep test, antigen testing, followed by a throat culture are what you need on your test. An HIV PCR from the blood, again, that's for infants or neonates. For this kid, you would do an HIV antigen antibody combo or fourth gen testing to screen for HIV. And there's no indication this kid has Lyme disease, either from an epi standpoint, so you wouldn't need to do Borrelia. So you would do CMV, IgG, and IgM. So when we talk about this particular kid, right, 16, so the age, we think about mono, palpable spleen tip. So the serologies are what tell you it's not EBV, and it's because of this, right? So the kid's VCA IgM was negative, which is not uncommon, even for kids with EBV mono, because you have to catch it in time. And it kind of goes up quickly and down quickly, up quickly, down quickly. And his was negative. His EBV VCA IgG was positive, which slowly becomes positive over time, but stays positive forever. If this kid's EBNA IgG had been negative, then you could say maybe this is EBV doing it because he hadn't developed an EBNA IgG yet if it were negative. Because his was positive, chances are it was way over here. So once you have EBV infection, your EBNA and EBV VC IgG are going to be positive pretty much for life. And so when those are positive, you can't really tell where the EBV infection occurred, other than is at least a few months ago, at least, if not a few years ago. So for this kid, the likelihood of the etiology of the mono is going to be CMV. So just think about EBV and CMV can both cause mono-like illness. EBV is usually asymptomatic. In kids and young kids, it's going to look like a cold. And teenagers, it's unfortunately going to be something like mono. No, it's associated with lymphoproliferative disorders, in particular, folks who are on immunosuppressive drugs, and there is an association with lymphoma and nasopharyngeal carcinoma. CMV, we are talking about congenital infection. CMV is actually more likely to be asymptomatic than EBV, but we do get concerned about it in kids who are severely immunocompromised. So, question 34. A mother makes an appointment to see you tomorrow for her 13-month-old immunized son with 2 days of fever, fussiness, and cough. When they arrive, mom states that he is no longer febrile and is playful, but he has now developed a red rash. Exam confirms he is afebrile and interactive with a diffuse maculopapular rash, but is otherwise stable. Which is the most likely etiology for his signs and symptoms? A, rubella, B, measles, C, German measles, D, HAV acute retrovirus syndrome, or E, HHV6. All right, so the answer is E, HHV6, which most got. So this is immunized 13-month-old, so rubella and measles are going to be unlikely answer choices. German measles is actually just another name for rubella, so it wouldn't be rubella. And then acute HIV retroviral syndrome, there's no indication to say that this is acute antiretroviral syndrome, which nobody guessed anyway, right? This is HHV 6, also known as roseola, that can often produce febrile seizures and be a case of meningoencephalitis like we talked about earlier. Human herpesvirus 7 presents similarly as a roseola-like syndrome, except they tend to be slightly older than kids with HHV6, and then there's HHV8, which we see in folks with AIDS. So remember, it's HHV6 is fever goes away, rash comes up, baby looks fine. That's roseola and HHV6. All right. Case 35, a family of 4, 2 parents and 2 daughters, preparing a well-earned summer vacation when they hear an unusual sound coming from inside the house during lunch. Nothing is seen when checking it out, but the sound continues for a few days at random times. The night before they leave for their vacation, they find a bat in the living room and realize it is a source of the noise they have heard. They attempt to capture the bat, but they are unsuccessful. All the family members are healthy, though one daughter had a reactive airway disease as a toddler. The most appropriate management for the family is A, supportive care, B, rabies, immune globulin, and vaccine for all family members, C, amoxiclav prophylaxis for all family members, D, rabies vaccine for the children, or E, rabies vaccine for the parents. All right, so the answer is B, rabies, immune globulin, and vaccine for all family members. So this is amoxiclav prophylaxis would be usually for bites, especially cat bites when we're thinking about Pasteurella multocida. And then from a vaccine for the children versus the parents, there is no age disparity or in terms of who gets vaccine or who gets immune globulin. Despite 3% of y'all wanted to only give it to children and not to the parents. So in full disclosure, this is my family. This is what happened to us. And so we had to go get rabies, immune globulin, and vaccine for all of my family members right before we went on vacation. So the idea is that we slept with a bat in our house, and there was no way to know that we were bitten or not bitten, especially in pediatrics. You're not necessarily going to know that there's a bite from a bat. We try to capture the bat as much as you can in order for it to be tested. If you capture the bat, then you don't need to institute vaccine or immune globulin right away. You can wait for the necropsy of the bat to determine whether or not the bat had rabies. The symptoms of rabies virus is restlessness and excitation, and typically you're going to have hydrophobia with severe spasms of the airway when affected person sees food or water, and oftentimes it's a diagnosis through a biopsy. So post-exposure guidelines depends on what you came in contact with, dogs, cats, and ferrets. If they have suspected rabies and you want to go ahead and start prophylaxis immediately, if they're healthy and available for observation, you do not need to do prophylaxis. If they're unavailable, this is when you contact your local health department to determine if there's been any cases of rabies in those particular animals. For raccoons, foxes, skunks, coyotes, and bats, you consider them rabid until you're able to test. And then large rodents, small rodents, livestock, rabbits, and other mammals, this is when you would contact your public health department. So one thing to remember is that non-mammals do not harbor rabies vaccine, so you don't need to worry about exposure for them. If the boards give you that they found a bat in the room and you didn't have your eyes on the bat the entire time they were in the room, then you consider that you need to give post-exposure prophylaxis to individuals. The post-exposure recommendation is to give immune globulin as much as possible as around the wound if that's available for you. And then you also give the rabies vaccine the day of exposure or the day when you seek medical care, 3 days after that, 7 days after that, and 14 days after that. It used to be a 5-course treatment plan with day 28 being the last day, but we don't need to do that for immune normal patients. If you immunocompromise, we still do the 5th dose at day 28. All right, question 36. This is not about my family. A 4-year-old immunized male has developed watery diarrhea about 4 to 6 episodes per day, and he complains of belly pain but has not had any accidents. The diarrhea has lasted for a few days, and parents have noticed some mucus but no blood. Not had any fever. He attends local daycare, but he has not traveled outside of the country. Mom has started having loose stools this morning and some abdominal cramping. Temperature on exam is 99.1, heart rate of 100, blood pressure 100/60, and respirations 20. There's some discomfort with abdominal palpation, but soft, and there's no rebound. He has no rashes or joint swelling. The cap refill is less than 2 seconds, otherwise unremarkable. The stool culture is positive for Shigella. So they give you the diagnosis, so then what's the question they want to know? In order for him to return to daycare, this patient must have fewer stools per day and which of the following? A, at least 3 stool samples that are negative for the pathogen. B, at least 2 stool samples that are negative. C, at least 1 stool sample that is negative. D, at least 2 negative PCR stool samples. Or E, no stool samples are needed. As a reminder, this is Shigella. All right, so C, at least 1 stool sample that is negative for pathogen. Most said no stool samples are needed, but for Shigella, it's more contagious than Salmonella, non-typhi. So for Shigella, you need at least 1 stool sample that is negative. Some states require 2, but the Red Book says you need at least 1. All right, 37. A 4-year-old immunized male has developed watery diarrhea, 4 to 6 episodes per day, and complains of belly pain, but he has not had any accidents. The diarrhea has lasted a few days, and parents have noticed some mucus, but no blood. He's not had any fever. He attends local daycare, but has not traveled outside of the country. Mom has started having loose stools this morning and some abdominal cramping. Temperature 99.1, heart rate 100, blood pressure 100/60, with respirations of 20. Now on exam, there's some discomfort with abdominal palpation, but it's soft and no rebounding, no rashes or joint swelling, cap refill of less than 2 seconds, and otherwise unremarkable exam. Stool culture is positive for Salmonella non-typhi species. So in order for him to return to daycare, the patient must have fewer stools per day, and which of the following? A, at least 3 negative stool samples. B, at least 2 negative stool samples. C, at least 1 negative stool sample. D, at least 2 negative PCR stool samples. Or E, no stool samples are needed. All right, so this is Salmonella non-typhi, in which case the no stool samples are needed to return, and most of you got that. Fantastic. 38. A 4-year-old immunized male, sound familiar, has developed watery diarrhea and complains of belly pain but not had any accidents. The diarrhea has lasted a few days and parents have noticed some mucus but no blood, no fever. He does attend local daycare and he's not traveled outside of the country. Mom has started having loose stools this morning and some abdominal cramping. Temperature is 99.1, heart rate 100, blood pressure 100/60, and a respirations of 20. There's some discomfort with abdominal palpation, but soft and no rebound, no rashes or joint swelling. Cap refill is less than 2 seconds. He has a rash on his abdomen, but otherwise unremarkable. Stool culture is positive for Salmonella cerevisiae typhi. In order for him to return to daycare, the patient must have fewer stools per day and which of the following? At least 3 stool samples that are negative, B, at least 2 stool samples that are negative, C, at least 1 stool sample that is negative, D, at least 2 negative PCR stool samples, or E, no stool samples are needed. So this is typhi. So it's a much bigger public health concern, and so they require 3 stool samples to be negative in order to return to daycare. Again, Salmonella, non-typhi, you don't need anything to return other than just clinical improvement. For Shigella, you need at least 1, and for Salmonella typhi, you need at least 3. Don't forget, when you talk about Salmonella non-typhi, you think about that causing bacteremia and osteoarticular infections in sickle cell kids. And then typhoid, you're usually going to see it in travelers coming back to the country from elsewhere. So a little bit about diarrhea. I think GI covers some of this as well, but viral causes of diarrhea are pretty common, especially norovirus. They might give you a clue that they went on a cruise ship. Rotavirus is very common, less common now with vaccines. But remember, rotavirus isn't just lower GI symptoms, it can have upper GI as well. And then adeno 4041 can do it and cause more prolonged symptoms. Bacterial typically is E. coli, so you have enterohemorrhagic E. coli. This is the ones you do not treat because this is oftentimes Chicken-toxin producing E. coli. Enterotoxigenic is also known as traveler's diarrhea. That tends to be pretty watery. You treat that with azithro or quinolone. Enteropathogenic E. coli, you typically see that in kids less than 2, oftentimes in resource-limited countries. EC, enteroinvasive, typically looks like dysentery. And then EAEC, or enteroaggregative, tends to have prolonged diarrhea similar to adenovirus. Clostridioides difficile. So there's usually 2-step testing now. So our institution, we do a PCR test first and then look for toxin second. So toxin and glutamate dehydrogenase. Once you confirm the testing or the infection, you treat with metronidazole or PO-vancomycin. And so the pediatric guidelines still say metro or PO-vanco for mild to moderate disease. The adult guidelines, they've done away with metronidazole, but the pediatric guidelines still give you PO-metro for mild to moderate disease. If the infection is considered severe disease, then that's when you start with PO-vanco. But PED still does metronidazole. And one thing to remember about Clostridioides difficile is the spores cannot be killed with alcohol. So if you use alcohol foam, alcohol gel at your institution, that's not going to work to prevent the spread of C. diff. You need to use soap and water. Cryptosporidium, we've talked about Bacillus cereus. So we'll talk a little bit more about this later, but Bacillus cereus or B. cereus, you remember in med school, we'll talk about fried rice. So that's usually the emetic form, and there's also a diarrheal form, which has an incubation period up close to a day. But Bacillus cereus can cause invasive disease. From a GI standpoint, it can also cause endophthalmitis. Bacillus cereus can, in which case you need to treat with Vanco. Campylobacter, think about, they might give you a clue that they had stuffing with their Thanksgiving dinner. And so you think about Campylobacter then, causing GI symptoms, but also erythema nodosum. And you can associate that with Guillain-Barré or reactive arthritis. Yersinia species, so this is not Yersinia pestis or plague, this is other Yersinia species, including enterocolitica and pseudotuberculosis. They can cause a pseudoappendicitis syndrome, so the boards might give you a 10 to 14-year-old kid who looks like they have appendicitis, but all the tests you do for appendicitis is negative, and they've had some GI symptoms. They want you to think about your Yersinia tuberculosis or enterocolitica. You can also get diarrheal disease in infants cared for by infant caregivers who handle chitolines, which are hog intestine, and that's often seen in the South. All right, case 39. A 6-year-old male with a history of multiple ear infections leading to tympanostomy tube placement presents with intermittent diarrhea for 3 to 4 months, but no emesis. During this period, 2 stool tests sent by the PCP were positive for something mom cannot remember. His symptoms improve with therapy. On exam, he has a temperature of 99.9, and respirations 20, blood pressure 100/50, and a heart rate of 100. There's no focal tenderness to his abdomen, and tubes are present bilaterally, and they are patent. The test most likely to identify this child's condition is A, a serum IgM, stool culture, a serum IgA, serum immunoglobulins to diphtheria, or serum immunoglobulins to pneumococcus. Right, so serum IgA, right, this is likely IgA deficiency. You get recurrent sinus pulmonary infections. So what is the stool test that mom can't remember? What's the pathogen that you can see with IgA deficiency? Right, Giardia. Right, so the patient has Giardia. They can also have other intestinal disorders like celiac and inflammatory bowel disease that are increased risk for these kids. So again, the multiple ear infections with GI symptoms usually due to Giardia. Okay, so question 40. A 16-year-old male with a history of multiple ear infections leading to tympanostomy tube placement presents with intermittent diarrhea for 3 to 4 months, but no emesis. Has a history of pneumococcal pneumonia once when he was 12 years old, and again last year. His symptoms improve with therapy. His exam shows a temperature of 99.9, respirations 20, blood pressure 110/50, and a heart rate of 100. There is no focal tenderness to his abdomen, and tubes are present bilaterally and patent. The test most likely to identify this patient's condition is A, a serum IgM, B, a stool culture, C, serum IgA, D, serum immunoglobulins to diphtheria, or E, serum immunoglobulins to strains in the pneumococcal conjugate vaccine. Right, so D, serum immunoglobulins to diphtheria. So this kid has CVID, so the recurrent sinus pulmonary disease, just like the IgA kid, but these are with encapsulated organisms. So he had 2 pneumococcal pneumonias, right? So encapsulated organism there. This is the most common presentation that occurred after puberty, so that's why we gave you an older kid for this particular case. And then you can consider looking at pneumococcal response, but you need to give the polysaccharide pneumococcal vaccine and look for the response to that, not the strains in the conjugate vaccine. And so in this case, you would do diphtheria response because the kid has already had diphtheria vaccination, presumably, and wouldn't have had polysaccharide vaccine. You would need to give the polysaccharide pneumococcal vaccine and then test the response to that. But for this particular case, you wouldn't do it for the conjugate vaccine. So a little bit about immunodeficiency, but immunology is going to go in much more detail. The things we think about from an ID perspective. So if you have a complement deficiency, in particular C5 through C9 terminal complement deficiency, that's where you're going to have Neisseria disease, especially invasive Neisseria disease. And so if you have a kid with invasive gonococcal or meningococcal disease, you want to think about terminal complement deficiency. And then chronic granulomatous disease. If you have a kid with recurrent infections due to one of these, serratia, nocardia, aspergillus, burkholderia, or staph, think about CGD. When we say staph, I don't mean kids who come in with recurrent cellulitis or recurrent superficial infections. This would be a kid who had invasive staph disease in the lungs twice and required VATS twice, or a kid who had 3 episodes of Staph aureus osteomyelitis with subperiosteal abscess before they're 2 years old, or twice before 1. I don't think there's a set number for that, but significant invasive staph disease is what we consider this for CGD. All right, case 41. An 11-year-old male with ITP who's been on steroids for the past 3 months, presents with cough for a few days along with fever and diarrhea. With the fever, he's had experienced chills and shakes, and his breathing has progressively weakened. Since steroid initiation, he has been using a humidifier and whirlpool bath for symptom relief. Exam shows a temperature of 101, heart rate 110, blood pressure 115 over 75, and an SpO2 of 84% on room air that would improve to 95% with 3 liters per minute. He has mild respiratory distress and rales at the left base, but no rash. A chest x-ray shows patchy alveolar infiltrates on the left and a possible effusion. The best test to diagnose this underlying illness is A, a Legionella urine antigen, B, Mycoplasma IgM, C, a CT scan of the chest with contrast, D, serum galactomannan, E, AFB stain and culture from the sputum. All right, so this is going to be a Legionella urine antigen. All right, which you all got. So mycoplasma serologies are not very good, especially Mycoplasma IgM can be positive for many months, if not a year after your acute infection. So it has a very limited value in testing. A CT of the chest, while it might be helpful, it's not going to be diagnostic for what you're looking for. A serum galactomannan is what you send when you're thinking about an Aspergillus infection. And an AFB staining culture from the sputum is what we send when we're concerned about Mycobacterium tuberculosis. But no, the answer for this is Legionella. Again, the steroids put them at risk from an immune compromise standpoint, and then the humidifier and whirlpool bath. So think about moist environments. There was a lot of concern sort of as we were coming out of the COVID pandemic that a lot of the buildings that went unused for a number of months, once their air conditioner systems got back up and running, that'd be a outbreak of Legionella. So think about sort of those environments. And then the chest x-ray shows patchy alveolar infiltrate, which is usually seen with Legionella. Interstitial disease is more commonly seen with your atypical pathogens, and Legionella often tends to be unilateral as well. It's pretty rare in childhood disease. Think about it when you have pneumonia and GI symptoms. You would also want to think about maybe some like Ascaris strongyloides as well, but they're usually going to give you something in terms of epi to think about Legionella. You can have CNS disease or CNS manifestations, and the treatment is usually azithro or levofloxacin. Again, this is a situation where it's okay to give a kid quinolone if they need it. In terms of atypicals, so we think about mycoplasma, which lacks a cell wall, and then chlamydia and Legionella, which are both intracellular. And then other atypicals include your acute doxycycline deficiency states. And so those are things like rickettsia, Coxiella, and then Ehrlichia and Anaplasma. AFB, so we talked a little bit about non-tuberculous mycobacterium and TB already. And then actinomyces, which we'll have a case of in just a few minutes. So mycoplasma is a frequent cause of respiratory tract infections in kids. It can be very mild for the most part, although it can be more severe or very severe. Most of the time it's going to be what we call walking pneumonia in about 10% of the time, or they can have prolonged symptoms. Some develop a maculopapular rash known as erythema multiforme, which can also be due to group A strep. CNS and cardiac diseases are uncommon. It can be a source of acute chest syndrome in kids with sickle cell disease. And then the autoimmune diseases that can be associated with include hemolytic anemia and Stevens-Johnson's-like syndrome. It tends to be in school-aged children and young adults with no particular seasonality. There is no long-term immunity, although serologies aren't great because you'll have positive serologies for quite some time, as well as asymptomatic carriage for weeks to months. The typical diagnosis is usually PCR is the preferred test. Serologies are okay, but they're not good. It's better if you get them acute and convalescent serologies, although with the availability of PCR testing now, we tend to do those. And I've never actually sent a mycoplasma culture, nor seen one positive for that matter. So those are slow and not very sensitive. The treatment, as you probably all know, is a macrolide, right? Whether azithro, clarithromycin, or erythromycin. Tetracyclines are okay for kids older than 8, and quinolones are okay in adults. For chlamydia, this is where we think of typically in adolescents, chlamydia pneumoniae in particular. There can be person-to-person spread, and the treatment for this is macrolide and tetracycline as well. So chlamydia psittaci or psittacosis, this is birds, especially poultry. We get a couple hundred cases a year, but it's likely higher. EpiClue is they're going to give you a pet store owner who has exposure to birds that may or may not be ill. There has not been foodborne transmission identified by handling infected poultry. The clinical symptoms look like respiratory tract infections with pneumonia and some splenomegaly, and you can have really decently high fevers with psittacosis. We do serologies for this, although some reports of PCR availability, although we've never sent that, and the treatment typically is a tetracycline, which is doxycycline. Chlamydia trachomatis. So this is something that newborns get from their moms traversing the birth canal. Eye ointments at delivery do not prevent transmission like they do for gonorrhea. For chlamydia trachomatis, you're going to have manifestations in the first few months of life. You can have pneumonia, and that's the chest X-ray they might give you has hyperinflation. The other thing they're going to mention is eosinophilia in the first 6 months of life. With the kid consistent with pneumonia, you want to think about chlamydia trachomatis. The treatment is oral azithromycin. We tend to use that more than Clarithrol and Erythro for the concern of pyloric stenosis with the others. Although you can see it with azithro, it's just far less common. All right, question 42. A 16-year-old immunized female whose mother teaches at UNC Chapel Hill presents in August with fever, lethargy, nausea, vomiting, and a rash that started on the hands and wrists. The rash has red spots and is starting to spread to arms and develop on the legs. Temperature is 101.1 with a heart rate of 110, blood pressure 120/75, and respirations of 20. There are erythematous macules on the wrist and arms, but no petechiae. There's periorbital edema. On labs, platelets 110,000, a sodium of 129, and ALT of 149. Labs are otherwise unremarkable. The best antibiotic for this child is A, vancomycin, B, amsulbactam, C, penicillin, D, doxycycline, or E, TMP SMX. All right, so D, doxycycline, which very many of y'all got. That's fantastic. Okay, good deal. So we'll do this one. A 6-year-old immunized female whose mother teaches at UNC Chapel Hill presents in August with fever, lethargy, nausea, vomiting, and a rash that started on the hands and feet. The rash has red spots and is starting to spread to the arms and develop on the legs. Temperature of 101.1, heart rate 110, blood pressure 110/65, and respirations 20. There are erythematous macules on the wrists and arms. No petechiae are noted. Periorbital edema is noted. Platelets are 110,000, a sodium of 129, ALT of 149. Labs are otherwise unremarkable. The best antibiotic for this child is A, vancomycin, B, amsulbactam, C, penicillin, D, doxycycline, or E, TMP SMX. All right, D, doxycycline. And most of y'all got this, great. So what do these kids have? Rocky Mountain spotted fever, excellent, good deal. Right, the hyponatremia, the rash, the location, right, UNC Chapel Hills in North Carolina. And the treatment for the older kid is doxycycline. Even for this kid who's under 8, the treatment is doxycycline. We do worry about T staining with exposure to tetracyclines, but that tends to come with repeated exposure or prolonged exposure. A course of a tetracycline for rickettsial disease is indicated and should not cause teeth staining in those situations. And so it's a drug of choice for any rickettsial disease. All right, next question. A 6-year-old immunized female whose mother is CEO of Mayo Clinic in Minnesota presents in August with fever, lethargy, nausea, vomiting, and a rash that started on the hands and wrists. The rash is red spots and starting to spread to the arms and develop on the legs. Temperature is 38.3 Celsius, a heart rate of 110, blood pressure 110/65, the respiration is 20. There are erythematous macules on the wrist and arms. No petechiae are noted. and there is periorbital edema. Labs show a platelet of 110,000, sodium of 129, and an ALT of 149, but the labs are otherwise unremarkable. Most likely etiology of her illness is A, anaplasma, B, rickettsia, B, babesia, D, ehrlichiosis, or E, coccidioides. All right, so this is anaplasma, right? Given the geographic location, which most of y'all got, rickettsia is Rocky Mountain spotted fever, which we're not going to really see way up in Minnesota. You're going to think about more anaplasma. Rocky Mountain is going to be, again, the Arkansas, Missouri, Tennessee, North Carolina, Mid-Atlantic area. Babesia is going to be Northeast and Mid-Atlantic. Ehrlichia. So if this were Louisiana instead of Minnesota, it would be Ehrlichia. But because it's in the north, it's going to be anaplasma. And then coccidioides is going to be illness seen in the Southwest. So a little bit about rickettsial diseases, which are basically known as doxycycline deficiency diseases. The rash typically starts in the peripheral as macules then progress inward, evolving to petechiae. You can have severe headache with this, as well as altered mental status. The diagnosis is usually with serologies, and clues are given by geography. And usually they have pretty good response to doxycycline. So once again, Rocky Mountain spotted fever, where it looks, where it lives, Ehrlichia, where it lives, anaplasma, where it's concentrated. So think about geography when it's helpful. And we'll move on. Case 45, a 3-year-old female with short gut syndrome requiring chronic TPN and intralipids via long-term central catheter line presents with 2 days of fever and decreased activity. She was admitted to your service a few weeks ago for a line infection due to E. coli and was treated with broad-spectrum antibiotics for 2 weeks to salvage her line. On exam, temperature is 100.9, heart rate of 115, respirations 20, and blood pressure 90/52. The line is at the right anterior chest wall without erythema. There are no rashes, lungs, and heart are unremarkable as well. A blood culture from the CVL grows, quote, yeast at 15 hours, and a peripheral culture turns positive at 21 hours for yeast also. In addition to line removal, what is the most appropriate empiric therapy to initiate? A, PO fluconazole, B, IV amphotericin, C, IV fluconazole, D, PO itraconazole, or E, IV inagilofungin. All right, so the answer is C, IV fluconazole, all right, which most of you got. So if we look at this, right, so long-term central line, so we get concerned about a line infection. So that could be gram-positive, could be gram-negatives, could be yeast. Typically when it's yeast, we tend to remove the lines. The yeast is, the patient has a risk factor for yeast because of broad-spectrum antibiotics that were recently given. And then the CVL grew first, which likely represents line infection as opposed to it being gut translocation because the differential time to positivity is more than 2 hours. So the likelihood that the CVL is the source is indicated there. You could give PO fluco because it does have really good bioavailability, but when there's invasive disease such as this, you want to do IV initially. Echinocandins like micafungin or caspofungin are decent options as well. Itraconazole would be okay for mild to moderate spore trichosis and histoplasmosis, but not for invasive yeast disease. Inagilofungin is a consideration, but we don't have much PEDS data, and so the preferred choice in this scenario would be IV fluco. So when you think about Candida species and their predisposing factors, right, so we just talked about broad-spectrum antibiotics, typically if they're a neonate and don't have great immune system to begin with. If someone's on steroids long-term, they're at increased risk for Candida species, along with malignancy and the presence of hardware, in particular IV and urinary catheters. So it can present in a lot of different ways. We in ID typically see it once it becomes invasive, but it can also obviously present as oral candidiasis, in which case nystatin typically is the drug of choice. It could be superficial, so causing diaper dermatitis or intertrigo or vulvovaginitis. in which case you typically use topical therapy, except for vulvovaginitis when you use PO therapy. So this is Candida diaperdermatitis, usually well-circumscribed lesions like you see at the top that are satellite in nature. And then we're going to continue with some fungus. Case 46. 15-year-old immunized, previously healthy female went hiking in western Ohio almost 3 weeks ago and now presents with cough and intermittent fevers up to 100.7, starting a few days after her hike. She lost about 5 pounds during this time. She has dyspnea on exertion as well as malaise, but no known TB contacts. Her exam has a temperature of 100.1, heart rate 95, respirations 28, blood pressure 115/70, and her SpO2 is 97% on 4 liters of oxygen. She has occasional rhonchi on both sides, no rales, no murmurs, and no hepatosplenomegaly. This is her CT of her chest. So the most informative test to reveal her diagnosis is A, a respiratory virus PCR panel, B, a sputum for AFB stain and culture, C, a urine histoplasma antigen, D, a pneumocystis PCR from the sputum, or E, coccidioides, mycosis, IgG, and IgM. So urine histoplasma antigen, all right, great, which most of you got. So it's unlikely for this to be a viral infection. One, they're usually not going to give you a geography when they want you to answer with a virus. It's not common that a virus is going to cause you to have weight loss either. There are no TB risk factors to indicate an AFB stain in culture. There's no indication this patient has HIV or other immunosuppression to warrant PJP testing. Also, they're not going to give you geography if they want you to know it's PJP. And coccidioides, right, that's going to be in the Southwest, not in Western Ohio. So the answer is urine histo antigen. You can also do serum histoantibodies as well. So the rash most likely to be seen in this particular patient would be what? A, impetigo, B, erythema nodosum, C, erythema marginatum, D, erythema multiforme, or E, erythema chronicum migrans. All right, the answer is erythema nodosum, which most of you got. That's fantastic. So impetigo, you're not going to really have an association with anything other than a superficial skin infection due to group A strep or Staph aureus. Erythema marginatum, we see with what? Rheumatic fever, right? That's the rheumatic. That's E. Erythema multiforme is usually seen with mycoplasma. You can see with HSV or group A strep as well. And then erythema chronicum migrans is seen in what? Lyme disease. Excellent. So other things you can see erythema nodosum show up with is Campylobacter infections. You can occasionally see it in TB infections, but it's not quite that common. Streptococcal infection is probably the most common, and you can also see it in sarcoidosis. So as a reminder, geography is important. So we think about histoplasmosis. Usually it's going to be asymptomatic. Oftentimes it's not realized that someone has it until decades later when they get an X-ray done of their chest and see calcified granulomas in the lung. You can have acute disease, as in the vignette that we just shared. You could test using urine histoantigen or serum histoantibody. If it's very mild, you can do supportive care. If it's moderate to severe, we usually do therapy with itraconazole, and when it's severe or has fibrosis, we typically do amphotericin. But this is the geography in the purple. Right? A blasto has a very similar geography. These are also mostly asymptomatic but can disseminate. We want to treat all patients who have blastomycosis. So if you're thinking about histoplasmosis, you should be testing for blastomycosis as well. And the treatment is very similar, itraconazole and amphotericin B. And then coccidioidomycosis, and mostly asymptomatic and oftentimes mild, although when symptomatic, you can have cough, fatigue, malaise. It can disseminate to cause systemic illness in about a quarter of the time. And we diagnose this with serology as well, and treatment, if needed, is usually fluco or amphotericin B. Okay, kind of staying on fungus. So aspergillus, there are a couple of different ways it shows up. So angioinvasive disease in immunocompromised patients, think about your stem cell transplant kids. So this could be anywhere, lung, CNS, sinus, cutaneous. This is why it's really good to get a good oral pharyngeal exam on these kids. ABPA is usually a hypersensitivity lung disease with mucus plugs and eosinophilia. Allergic sinusitis, which has chronic sinusitis with dark nasal discharge. In immune competent kids, you can get otomycosis. We see this often in clinic where we'll culture it and it'll come back aspergillus, which is not an allergic component and it's usually not terribly invasive, but it does require treatment for the most part. Diagnosis is culture. Sometimes we can do serum testing for the galactomannan, and that can be positive for us. Treatment of choice is usually voriconazole. Occasionally we can use amphotericin B, and then surgery if needed for more invasive stuff. Tinea pedis or athlete's foot. It's uncommon in very young children, but very common in adolescent and pre-adolescent males. Usually by the fourth and fifth toe are the most common sites. It's usually from occlusive footwear, so make sure you tell the teenagers to dry their toes really well after taking a bath. Treatment is usually topical with clotrimazole or miconazole. All right, a little more tinea for us. Which is the preferred treatment for tinea capitis? A, fluconazole, B, griseofulvin microsize, C, terbinafine, D, griseofulvin ultra microsize, or E, any of the above if you treat long enough. So E, any of the above, if you treat long enough, is the answer. So you can give any of these, and if you treat it long enough, it'll work. This is not going to be the case for any infection you treat. So just make sure it's not going to be, if you treat cellulitis for 5 weeks, that's not the answer for this. But just for this particular infection, tinea capitis, doesn't matter which of these you use, you just need to treat it long enough, and it's usually going to be a clinical response that you'll see. Malassezia species, so I put invasive in here because I'm not going to really talk about pityriasis versicolor that you see with Malassezia, but this is for kids who have invasive Malassezia disease. Typically, they're going to be neonates or premature, low birth weight, and lipid supplementation. Clinical features are oftentimes asymptomatic. They can have sepsis and show thrombocytopenia, hepatosplenomegaly, leukocytosis. Again, somewhat nonspecific, but having a thought of if these kids are on lipid hyperalimentation to think about Malassezia as a source. You need to let the lab know to do an olive oil overlay to the medium in order to grow the Malassezia, because it needs that in order to provide the long-chain fatty acids to show up on a culture. The treatment is usually to stop the lipids and take out the catheter and give amphotericin B. The one thing to know about amphotericin, so usually old school amphotericin deoxycholate is pretty well tolerated in neonates. They tend to flush it out pretty well. For non-neonates, the lipid formulations of amphotericin is much better tolerated. So you can give lipid form to older kids. Neonates are okay with deoxycholate. Sporotrichosis, so we mentioned this earlier in the talk, right? This is a fungi found in decaying wood and other vegetation. So you think about this from percutaneous inoculation, rose bushes, strawberries, Christmas tree, cutting, etc. So you're usually going to see a gardener, forester. It's usually a single lesion that ulcerates 1 to 12 weeks later. It can go along the lymphatics. Remember, we compared this to Mycobacterium marinum, which is the fish tank cleaners. So always think about that clue in the vignette whenever they talk about it. This is what it can start as and then proceed proximal. We typically culture is how we diagnose it. While you can do the drops per day that are voluminous, you can also do itraconazole orally. That's likely just as good. All right, a female patient is admitted with a sickle cell pain crisis. Yesterday, she was exposed to a cousin with varicella. She has not had varicella and has not been immunized against varicella. When should she be in quarantine? A, on admission. B, days 8 to 21 after exposure, even without a rash. C, days 1 through 10 after exposure, even without a rash. D, at the first sign of varicella and then until lesions crossed over, or E, at the first sign of varicella and then until day 10 after the lesions have occurred. All right, so day 8 to 21, even without a rash, right? So this is quarantine, not isolation. Right? So the answer D is really going to be when you have varicella or chickenpox, until the lesion's crushed over, you're contagious, right? So that's the difference between quarantine and isolation. I'm sure we all learned a lot more about quarantine and isolation since the pandemic started. So for this one, it's day 8 to 21 after exposure, even without a rash. So when we think about varicella zoster virus, the primary infection is what we lovely known as chickenpox, which is typically benign in children, although it can be worse in adolescents, adults, pregnant women, and immunocompromised. And so in this group, we typically give acyclovir, whether oral or IV, depending on the severity of immunocompromised state for the patient. So again, the most common complication of varicella is something we saw earlier, as secondary bacterial infection with Staph aureus or group A strep, more commonly group A strep. The most common CNS complication is transient cerebellar ataxia or encephalitis, and the incubation period is 10 to 21 days. Up to 28 days if varicella zoster immunoglobulin has been given, and then a quarantine days 8 to 21 after exposure. So the top picture is likely breakthrough varicella because you don't have that many lesions. Remember, chickenpox is going to be lots of these vesicular, pustular lesions that are in various stages of age, and just going to be voluminous, like the bottom picture, as opposed to the top picture where you can get breakthrough infection, especially after vaccine administration, and usually get 50 to 100 lesions all over your body, as opposed to natural varicella infection where you're going to get hundreds of lesions per extremity. So if varicella is a primary infection in pregnancy, it can have detrimental effects on the infant, especially if it occurs 8 to 20 weeks during gestation. So you get limb atrophy, microcephaly, seizures, and chorioretinitis. When you have a seronegative pregnant person who is exposed to varicella, you want to make sure you give the Varizig, varicella immune globulin within 4 days of exposure, but we do not give a varicella vaccine because it is a live virus. The ideal time to give that is before they become pregnant. So this is limb atrophy seen in a newborn who had in utero infection. So the risk you get concerned about are infants born to mothers who develop varicella less than 5 days before delivery or within 2 days after the delivery. So we think about varicella, you think about V, the Roman numeral 5, so 5 days before delivery, and then the 2 L's are Roman numerals 1 and 1, so 5 days before, 2 days after delivery. And these are the kids who are at higher risk for severe infection. Remember, this does not apply to zoster, which is a secondary infection. So mom will have more immune globulin than having chickenpox, and so you don't have to do as much for those kids. Treatment for chickenpox, usually want to do oral acyclovir. If you're immune normal adolescent or young adult, you can do acyclovir or valacyclovir. If you're immunocompromised, you typically want to give IV therapy instead of PO therapy. Zoster is somewhat similar to immunocompetent host. You can give acyclovir or famciclovir or valacyclovir. We do not give steroids for these particular patients. This is the dermatomal distribution that we typically think of with a zoster infection. Okay, moving on. 49, a 7-year-old immunized male presents with fever, malaise, nausea, vomiting for a few days. Sister had similar symptoms last week and is now back to baseline. Part of this kid's evaluation in the ED included a CBC revealing a white count of 11.4 with 57% PMNs and 37% LIMPs. A blood culture is pending. He is sent home with reassurance and supportive care because he was able to tolerate PO in the ED and his vital signs were reassuring, other than a temperature of 100.9. The lab calls says his blood culture is growing diphtheroids at 22 hours. You call the parents to let them know, and they tell you he is more active, tolerating PO, but did have a temperature of 100.3 right after arriving home from the ED, but no fever since. The most appropriate next management step is A, call back tomorrow to ensure he is doing well. B, return to the ED for another blood culture. C, return to the ED for blood culture, throat culture, and repeat CBC. D, admission and start IV AMP and GENT. Or E, admission and start IV Venco. All right, so call back to ensure he's doing well, which some of you got. So we're going to go through these answers after the next question. A 7-day-old immunized male presents with fever, malaise, nausea, vomiting for the last 24 hours. Sister had similar symptoms last week and is now back to baseline. Part of the evaluation included a CBC that had a white count of 11.4 with 57% PMNs and 30% LEMPs, blood culture pending. Sent home with reassurances and supportive care because he is able to tolerate PO in the ED, and his vital signs were reassuring other than a temperature of 100.9. Remember, this is just a question. I understand if a 7-day-old shows up with fever, you're going to do more than this, but just go with it for a second. The lab calls and says his blood culture is growing diphtheroids at 22 hours. You call the parents to let them know, and they tell you he was more active, tolerating PO, but had a temperature of 100.3 right after arriving home from the ED, but no fever since. The most appropriate next management step is A, call back tomorrow to ensure he's doing well. B, return to the ED for another blood culture. C, return to the ED for blood culture, throat culture, and a repeat CBC. D, admission and start IV AMP and GENT. E, admission and start IV vancomycin. All right, so the answer is D, admit and start IV AMP and GENT, which most of you got, right? So the thing you're concerned about for this particular 7-day-old is listeria, right? So that's what you think about. So you think about the prior question, which was the older kid who likely had a contaminant due to diphtheroid, which would be a gram-positive rod, which is usually a contaminant unless you're otherwise immunocompromised or have hardware, i.e. a central line. And so you wouldn't return to the ED for a kid who's otherwise healthy who has a likely contaminant on the blood culture. You don't need a throat culture or a CBC if they return to the ED. Now, had the blood culture returned gram-positive cocci or gram-negative rods, then likely would have brought them back and done blood culture and likely admitted them to the hospital, depending on how sick they are. And then you would only start Venco if you had a suspicion of a Staph aureus or strep pneumo infection, bacteremia, in which case the blood culture gram stain would have said gram-positive cocci. So thinking about listeria, the highest incidence is in the newborn period. The epi they're going to give you is exposure to deli meats or some sort of soft cheeses or contaminated milk. Sometimes they'll give you fruit like cantaloupes. There was an outbreak in Colorado over a decade ago. Again, for diphtheroid on CSF or blood in a neonate, you don't pick a contaminant. And the treatment for listeria is usually AMP or penicillin. You start GENT initially, and then you can pull it off. So continuing with other gram-positive rods. So Bacillus anthracis or anthrax, the most common manifestation is going to be a cutaneous infection followed by pulmonic. This is oftentimes going to be maybe wool sorters or something to do with sheep because of handling of hides or wool. It's going to be evolved from a painless papule into a painless black eschar that you can see here. The chest X-ray shows a widening mediastinum that you can sometimes see with pneumotic anthrax. This is a bioterrorism agent, as you probably are all aware, but it cannot spread from person to person, unlike pneumonic plague and smallpox. The treatment is usually quinolone like Cipro or doxycycline, although if you get susceptibilities that show it's sensitive to penicillin, that's what you would go with. Bacillus cereus, so we briefly mentioned this earlier in the diarrheal section. So there's a short incubation, usually a couple of hours. This is where you have the fried rice left out at room temperature, and you have the emetic form that is typically self-limited, and then the longer intubation due to enterotoxin and the GI tract, that's the diarrheal type. Again, both typically self-limited. However, Bacillus cereus can cause an endophthalmitis, especially after penetrating injuries, in which case you would need IV vancomycin for that treatment. Actinomyces, for those who have read the Red Book, this is the first bacteria in the Red Book listed, so this is exciting. It's usually clusters of organisms seen under this microscope. There are three main manifestations of cervical facial, which you see on the picture here, of a kid who had some dental work done 1 to 2 weeks prior to presentation. And you can have thoracic and abdominal, in particular females who have intrauterine devices. The treatment for actinomyces is usually going to be IV penicillin for the first 3 to 4 weeks, followed by 6 to 12 months of oral therapy also. Nocardia, this is a skin disease typically seen with soil contamination in immunocompetent children. It can be much more invasive in kids who are immune compromised, often causing cavitary pulmonary disease and CNS infections. It can grow in blood in about 3 to 5 days. They can stain acid-fast positive because they do have mycolic acid in the cell wall, unlike actinomyces, which does not stain acid-fast. The treatment for nocardia is going to be TMP SMX for mild disease, and then more aggressive therapy for severe disease, especially for those who are immunocompromised. Clostridioides, so also known as Clostridioides difficile, right? So that's the antibiotic associated. They're going to give you a clue that the kid has C. diff infection. Usually it's going to be exposure to antibiotics recently. But then we also have C. botulinum, right? So botulism, that blocks the presynaptic acetylcholine release. So this is the honey to babies. It can be from foodborne illness. It also can be a wound in origin. And if the wound is they're going to give you some sort of crush injury or gross trauma. You can also see it in users of heroin. The treatment is usually going to be an antitoxin as well as a human botulism immune globulin. If they ask what drugs should you not give patients with botulism, it's going to be any of the aminoglycosides because it can potentiate the harm that's coming from the presynaptic acetylcholine release. Clostridia perfringens can be a food poisoning or a diarrheal illness, usually from contaminated meat. It can also be a source of gas gangrene, as can Clostridium septicum, gas gangrene being Clostridial myonecrosis. It can be acute and progressive pain at the wound site, oftentimes after trauma. They can have exquisite tenderness. And then left untreated, it can cause severe muscle necrosis. Case 51. A 10-month-old female presents with runny nose and tons of congestion that has progressed to difficulty breathing over the past few days since returning from grandparents' Thanksgiving celebration. The exam shows a temperature of 100.8, a heart rate of 140, respiration is 40, SpO2 90% on room air. There are transmitted upper airway sounds heard along with wheezing bilaterally. There is some mild nasal flaring, and a beta agonist treatment is given with no change in the auscultatory exam. The most likely pathogen causing this child's illness is what? A. Adenovirus, B. RSV, C. Parainfluenza virus, D. Influenza, or E. Human metapneumovirus. All right, so this is RSV, which most of you got. This is fantastic. Adenovirus is going to have conjunctivitis usually, which this kid did not have. Parainfluenza is the causative agent of croup for the most part. While this could be flu or human metapneumovirus, you just need to know that RSV is going to be more common than those. So again, the timing, Thanksgiving, so that's sort of the beginning of flu season, but pretty decently into RSV season already. And then the beta agonist treatment with no change would suggest that it's a broncholytic picture, usually due to RSV. So typically peaks in the autumn and winter, RSV does. We can diagnose it using nasal secretion wash, which is historically what we use, but we can also now do point of care testing for antigens, but also PCR testing with the respiratory panel. We don't really have any treatment for it, but we do have some preventative measures for it. So namely palivizumab, the monoclonal antibody given to kids who are high risk for RSV in the first and second years of their life. So that may be on your test. Human metapneumovirus is the most common cause of RSV negative bronchiolitis. It can cause asthma exacerbations and even look like croup. Typically, we're going to have late winter, early spring versions of human metapneumovirus, so a little later in the winter season than you would see RSV, and a little bit later than you would see influenza. Typically, we'll diagnose this with PCR tests, but there's no direct therapy for human metapneumovirus. Paraflu, right? So this is usually causative agent of croup, in which case we give Dex. We all are no more educated about coronaviruses, so there are seasonal coronaviruses that still exist that cause common colds, occasionally lower respiratory tract infections, but then there are mutations of coronaviruses, namely SARS, MERS, and COVID-19 that can be severe, as we all know. Okay, question 52. A 14-year-old female presents with 5 days of fever, abdominal pain, and red eyes. She's had a few days of runny nose and nasal congestion about a month ago. Her brother was diagnosed with COVID-19 2 weeks ago. The exam reveals a temperature of 102.3, blood pressure 115/75, watery discharge from the eyes with conjunctival injection, and bilateral anterior cervical adenopathy. Which is the most likely etiology for her signs and symptoms? A, toxic shock syndrome, B, Kawasaki disease, C, acute COVID-19, D, infectious mononucleosis, or E, multisystem inflammatory syndrome in children. All right, so MIS-C would be the answer for this one. So it's not going to be Kawasaki disease, right? Because this kid's a little too old to have Kawasaki disease. And remember that one of the criteria is unilateral cervical adenopathy, and this kid has bilateral. Usually with, I know there are case reports of acute COVID-19 causing literally every symptom that exists. But for the most part, you're going to want you to know that this kid has MIS-C because of the exposure to COVID recently and not actual COVID infection currently. Mono seems less likely, especially given the red eyes, and not toxic shock because they're not hypotensive. So MIS-C would be the answer for this one. So thinking about SARS-CoV-2 and MIS-C, again, acute infection for COVID is going to have pretty non-specific symptoms with the exception of losing your taste and smell. It's rarely life-threatening in pediatrics, fortunately. And we do have therapy for it in inpatient. There's still use remdesivir plus minus depending on the severity of illness. Multisystem inflammatory syndrome in children is usually 2 to 6 weeks after acute COVID-19 infection, where you'll have fever, GI symptoms, conjunctivitis, and rash. Usually the age, such as this vignette, and then COVID-19 that will differentiate it from Kawasaki disease. Now, can you have a 4-year-old who had recent exposure to COVID-19 have MIS-C that looks exactly like Kawasaki disease? Yes, but the boards are going to try to differentiate that for you. For MIS-C, we give IVIG for mild disease, and then we add steroids to that for more severe disease. So thinking about other respiratory viruses, so the flu, right? Think about myalgias in particular. They'll give you a clue to give that. You can also have lower respiratory tract infections. And then certainly with our first case that had a secondary bacterial infection due to staph, we can see that. And this is, again, rapid antigen testing, usually point of care, or PCR testing. We treat this usually with oral oseltamivir for kids who are hospitalized. No, regardless of how long the symptoms have been going on, if flu was severe enough to admit them to the hospital, regardless of their duration of symptoms, you give them oseltamivir. If they're a high-risk outpatient, or if they're not high risk but presented within 48 hours. And the best way to prevent influenza infection is your annual flu vaccine. And remember, kids who are less than 9 who have never had a flu vaccine need to get 2 doses at least 4 weeks apart. Enteroviruses, so we're going to go through a little bit of these, right? So enteroviruses is a large family of different viruses, usually Coxsackie, Echo, Entero, and polioviruses. So hand, foot, and mouth disease, which we see often. Typically going to have fever, and then papules or vesicles of the buccal mucosa, tongue, lips, and gums. You'll get a red rash on the hands and feet that may become vesicular, and this is typically due to Coxsackie viruses or enterovirus type 71. So these are sort of the papular vesicular lesions you can see on the extremities, and then my daughter who had it as well. Other enteroviral diseases, so you can get acute hemorrhagic conjunctivitis, usually due to one of the enteroviruses and a Coxsackie virus. Herpes angina is usually a Coxsackie infection, which you can see with sore throat. Myocarditis and pericarditis is usually going to be one of the Coxsackie viruses or echovirus. Difficulty is diagnosing these. We typically rely on serologies, so the IgM really needs to be positive because IgGs are not going to be evident of acute infection. And it's a pretty common cause of aseptic meningitis, especially in the summer, between enterovirus and parvovirus. Okay. Question 53. A male college student presents with cough, coryza, and conjunctivitis. His parents do not believe in immunizations. A red maculopapular rash now develops. He is febrile and miserable, but otherwise stable. Which is the most likely etiology for his signs and symptoms? A, rubella, B, measles, C, German measles, D, acute HIV retroviral syndrome, or E, HHV6. All right, so this is measles, which most of you got, right? The 3 C's, cough, coryza, conjunctivitis. You can also get the Koplik spots as an anthem. Rubella, we sort of talked about before, having postnatal disease. You're going to have a rash. And you can sometimes have lymphadenopathy, conjunctivitis with it as well. German measles is also known as rubella. And HHV6 is going to be roseola, which this kid does not have. So measles, also known as rubeola. The rash is going to start at the hairline at the top and work its way down. Vitamin A deficiency can produce more severe disease. We typically diagnose this with serology or PCR from an oropharyngeal area. And then you do get post-exposure prophylaxis, and you give that via vaccine down to 6 months of age within 72 hours. If this happens and you give the measles vaccine before the first year of life, then this does not count as their 2-dose vaccine series. You have to still give the 2 doses. This is a picture of what it looks like as it's moved down onto the trunk. Other viral things that can cause rashes that we think about, so erythema infectiosum, also known as Fifth disease. The key thing to remember they might ask about is when can the kid go back to daycare? Usually once the rash appears, they are no longer contagious, and so that's when they can go back to school. It can cause more severe manifestations in kids with sickle cell disease, namely transient aplastic crisis, or chronic anemias in those who have leukemia or other immune deficiency. They can have this polyarthritis that resolves after a few weeks. And then if a teenager has it when they're pregnant, while most instances may be normal, there is a small % of fetal demise. We diagnose parvovirus either with PCR or we do serologies. This is a happy kid who's ready to go back to daycare because the rash has erupted and they are okay to go back. Mumps, so we did measles, mumps. This is unilateral or more commonly bilateral parotid swelling. About a third of postpubertal males can have unilateral epididymoarchitis, and a third of adolescent females can get mastitis. CNS infection can be common and cause hearing deficit as a complication. This is your boy with the unilateral parotid swelling due to mumps. 14-year-old female presents 12 hours after sustaining a bite to her hand from her sweet, loving, loyal cat. The area has become red, slightly swollen, and tender, but she is able to flex and extend all her fingers. After you have thoroughly washed the area, the patient's mother informs you that his daughter has anaphylaxis with penicillin products. The note from our allergist in your EMR confirms the allergy. The best empiric antibiotic regimen to provide for this patient is what? A, ceftonir and dicloxacillin, B, cephalexin and TMP-SMX, C, clindamycin, D, TMP-SMX and clindamycin, or E, mupirocin and fluconazole. All right, so the answer is TMP, SMX plus Clinda. And so what if this kid did not have a penicillin allergy? What would you give him? Yeah, so amoxiclav, right? But the boards know you know that, and that's an easier question than giving somebody a penicillin allergy and you can't use it. So the treatment of choice for this one would be TMP, SMX plus clindamycin. So for ceftonir and dicloxacillin, the anti-staph penicillin diclox will not be sufficient for this particular case. And ceftonir would be fine for Pasteurella, but diclox is what does not work for this. Cephalexin, TMP-SMX, cephalexin is not what you want to use for empiric therapy for MRSA infections. And then clindamycin, again, we're worried about Pasteurella in this particular case with a cat bite, which is a gram-negative, and clindamycin has no gram-negative coverage, which is why D is the answer, because TMP-SMX will have it, while Clinda provides you some staph coverage as well. Sometimes the reason we do amoxiclav is because with the cat bites, they tend to puncture a lot deeper than, say, dog bites. And so we worried about a lot about Pasteurella. And so we'll do amoxiclav for polymicrobial concern. But again, if they're allergic, we do TMP-SMX and Clinda. So Pasteurella is more commonly in the mouths of cats, and you have quick development of swelling, erythema, and pain, and you can evolve into more invasive problems such as osteomyelitis. And again, empiric therapy is usually amoxiclav. So a little more gram-negative that we're going to sort of go through it here at the end. So gonococcal ophthalma, right? So this is newborns passing through an infected birth canal that is prevented with eye ointments at delivery. Typically, they present 2 to 7 days after delivery with bloody, green, or serous sanguineous discharge. You always want to do a gram stain of the eyes because if it's positive for gram-negative diplococci, you want to do a septic evaluation, including an LP. As a reminder, for eye discharge less than 2 days, it's usually a chemical reaction, 2 to 7 days, Neisseria. And then after the first week of life, you usually do chlamydia trachomatis. Pseudomonas, another gram-negative. So we think about that with IV, folks who use IV drugs and can cause endocarditis or osteomyelitis. You can also have a nail puncture through a tennis shoe causing Pseudomonas. In kids who are medically complex, they can cause recurrent UTIs. In a hot tub, they might give you, in someone who's lounging, it's usually a self-limited illness. You don't need to give systemic therapy for that. Unfortunately, there are a few systemic options we can use for Pseudomonas therapy, and pretty much all of them are IV except for the final one, fluoroquinolone. But all of these can be used for Pseudomonas therapy, and quinolone being the only oral option. So this is ecthyma gangrenosum, simply with this central ulceration. Sometimes it's black in nature. This is a harbinger of Pseudomonas bacteremia and possibly of an oncologic process. Vibrio vulnificus, oftentimes a skin soft tissue infection in the Gulf or warm brackish waters. They'll tell you they usually go in the summer. They can develop rapidly into septicemia, especially those who have an underlying liver disease. We do doxy and or Cipro for a mild disease, especially skin soft tissue infections. But for more severe disease or those who are at higher risk, we'll do a third generation cephalosporin plus doxycycline or sometimes a quinolone. A 5-year-old under-immunized male presents with congestion and runny nose for almost a week. The kid has no breathing difficulty. A 3-month-old frequent playmate with similar symptoms had to be hospitalized because he would stop breathing on occasion. Grandmother who lives with the patient has had a loud, hacking, non-productive cough. The exam reveals a temperature of 90.1, heart rate 105, blood pressure 100/65, and respirations 26. There are no focal findings on auscultation. The most contagious time period for this infection is A, the first 10 to 14 days, B, the third and fourth week, C, once the coughing subsides, D, once the rash develops, E, this infection does not spread person to person. All right, the first 10 to 14 days. All right, so most of y'all got this. What is this? Pertussis, right, absolutely. Right, so under-immunized person, they have congestion and runny nose, so that's the catarrhal phase, right, the initial phase looks like a URI. It also has the highest bacterial load at the time. The 3-month-old, right, so if you're less than 6 months, you're more likely at risk to have apnea. And then the grandmother has a loud hacking cough, so oftentimes kids are exposed to it from adults who have waning immunity. And then pertussis typically does not produce fever, and so that's why this particular kid was afebrile. The highest incidence of pertussis in kids less than 1, with the highest incidence of death in kids less than 2 months of age. Usually they're going to get it from an adult. The phases are catarrhal, paroxysmal, and convalescent, right? The catarrhal is the most contagious because nobody thinks of pertussis initially, right? So you think they have a URI, and well, before the pandemic, nobody cared that much about URIs. You could just still do whatever you wanted to do, but that's also when you had the highest amount of bacterial burden and be able to spread it a lot easier. Once you get to the paroxysmal phase, the coughing phase, treatment doesn't really change the course of your pertussis. The reason you still give these folks at the paroxysmal phase azithromycin is to prevent transmission to other folks. And then there's a convalescent phase. We typically diagnose this through PCR, and the treatment is azithromycin, and then the post-exposure prophylaxis is going to be the same with azithromycin. And then the main way to prevent this is through vaccination. So just a couple of slides on infection control. So as a reminder, universal precautions or standard precautions are the baseline for all patient care. That includes hand hygiene and then appropriate PPE. One thing to remember is you never recap safety needles in case that is asked. So there are airborne precautions, there's contact precautions, there's droplet precautions. So airborne precautions is what we typically think of for TB and measles and varicella zoster, where they need a negative pressure room, so everything goes into the room instead of out of the room, and providers should wear an N95 mask or a more complicated breathing apparatus. Droplet precautions is what we typically think of with respiratory viruses. Usually at least 3 feet of distance is good without needing a mask, but a surgical mask is required, and typically this is going to be what we call a level 2 mask as opposed to a level 1 mask or a level 1 cover your cough mask. For these pathogens, it's going to be meningococcus, pertussis, mycoplasma, parvo, and influenza. And then contact, right? These are things we think about with skin, soft tissue things. So this is a standard, plus you wear gloves and gowns, but you do not need to wear a mask. This is MRSA, RSV, Rota, Salmonella, and C. diff. Just remember the thing about C. diff is that we can't use a routine alcohol, foam, or gel. We need to be able to wash our hands with soap and water because the alcohol does not kill the C. diff spores. Okay, so the things that if I didn't mention these already, the things that I want you to take home from an ID perspective or non-ID perspective is that the BCG vaccine is usually there to create confusion, so just ignore it. Cephalosporins do not cover enterococcus, and so in particular, thinking about UTIs in kids who might have an enterococcal UTI that are empirically started on a 2nd or 3rd generation cephalosporin. If they're not getting better, it's likely because they have an enterococcal infection. Intracranial calcifications, the 2 things you need to know about are congenital CMV, congenital toxo. If they give you an epi history for intracranial calcifications, you think of congenital Zika. Rocky Mountain spotted fever or Ehrlichia and anaplasmosis, they are all doxycycline deficiency states. You give them doxycycline, regardless of the age. A history of maternal HSV puts baby at less risk of having neonatal HSV. And again, the UTI diagnosis requires pyuria and a high CFU per mil colony count. We talked about skin, soft tissue, bone, and joint infections being staph, aureus, and group A strep. High fever, then a rash, includes less than 2. It's going to be roseola. ESBLs, extended spectrum beta-lactamases, which we didn't spend much time on. I don't know how much is going to be on your boards, but typically you're going to use cefepime or meropenem for that. Hepatitis B core is only from infection. So those are the 2 cases we did earlier. And then one thing that helped me, I had questions about sensitivity, specificity, positive and negative predictive value. So just know that. That has nothing to do with ID, but it was very helpful for me when I took my boards. Thanks, y'all.